just to advise members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online. So, apologies. We have apologies from Nuala, Linda. Alan Chambers will be joined late. There's a, I don't know if it's an emergency briefing, but there's a briefing at the policing board from the Chief Constable, so obviously all three of those are policing board members. Can I just advise members in the public gallery that they're very welcome and very welcome to use mobile devices as long as they're in airplane mode, and all devices must be muted. You can connect to Assembly Wi-Fi. Password details are down there in the gallery rules. It's not permitted to take photographs or record any of the meeting. Chair's business, can I just thank the individuals who attended the committee's forum meeting this morning and formal engagement. It was extremely useful and we're very grateful to the individuals who attended, so thank you very much. Some of them are with us still. It was important for the committee to hear directly from people about their experience regarding accessing palliative care service for their loved ones. An audio recording of and the Hansard of the forum will be available shortly on the committee's web pages, so anybody that wasn't able to attend can go back and have a look at that or listen to it. Draft minutes of the meeting held on 5th of June 2025 are at page 6. Everybody content to agree the draft minutes? Thank you. Matters arising? None? Thank you. Okay, so moving in just to item number 5, oral briefing on the inquiry on access to palliative care services. So can I refer everybody to tab 5 of our pack? There's a clerk's memo, page 15, a response from the department on individual care plans. That's at page 12 of the table papers, which was shared with Dr. Cousins. And then we also have an RPMG individual care plan in table 2 of the table pack. So can I welcome Christine Campbell, Macmillan Cancer Experience Panel, Sarah Christie, National Lead and External Affairs Manager here in the North for Macmillan Cancer Support Services, and Dr. Cousins. Thank you. This isn't your first time here, so you're very welcome again. So Dr. Cousins is consultant in palliative medicine in the Southern Trust, and joining this meeting to specifically talk on the regional last days individualised care plan for hospital wards. So we have 45 minutes for this. You're very, very welcome. I'm going to hand over to yourselves just to give us a bit of a synopsis, and then we'll take questions from members.
Perfect, thank you. Well, I'm going to begin. We've arranged this beforehand, so thank you. Yes, I am back again. This is really in relation to regionalised last days individualised care plans. This was something I had discussed on my written submission, and I believe it was Alan Robinson who had picked up on this and asked a question. So, and to summarise then, yourselves as the committee had written to the Department of Health asking for an update on this, and the response came back yesterday, and the response was in the negative to a regionalised, individualised sort of last days care plan. That response really falls short of expectations. Okay. Indeed, the response states that this request is not appropriate at the top of the second page, and it raises concerns for me about the department's understanding of what I'm asking for, about what my colleagues have been asking for a long time. The response does not align with expert palliative, so medical, pharmacy, nursing opinion. It doesn't align with current practice in England and Wales, and it frankly doesn't make sense. So I am confident from my personal experience and for the experience of my colleagues that this is appropriate. Furthermore, 3/4 of the hospital trusts in England and Wales have one of these end-of-life care plans, lots of different names, but some sort of end-of-life documentation, 3/4. So this is, for very many years, over 10 years now, been a useful clinical tool. So let me outline. So firstly, we are talking only about documentation for hospital deaths. Okay, so hospital deaths, about 46% of all deaths in Northern Ireland occur in hospitals. Okay, so that's the majority of deaths occur in hospitals. Just for reference, about 4% happen in hospices. 20% in nursing homes or residential homes, and about 30% at home. So 45% is the most frequent place of death for people in Northern Ireland. But it's where satisfaction of the dying experience is the lowest. So when we ask bereaved relatives after the event, after the death of their loved one, how their experience of death was, so home and hospice rank highest, always high 90s for satisfaction, but hospital deaths are much, much lower than that, somewhere around the 60 or 70%, much lower. So where we're talking about is somewhere that we have the highest numbers of deaths, but the lowest satisfaction. And we need to ask ourselves the question then, what is our response to this? So one of the key solutions is a structured documentation to guide and improve care for those patients who are dying in their last days. So just to be clear, it's not Respect, it's not a DNA CPR, it's not an advanced care plan. It's regional, because as one region, we want a template that staff moving across different trusts are aware of, trained to, and it is standardised. It is last days. It is very, very specifically for those last hours and those last days when the patient is perhaps unconscious, the family are perhaps holding a vigil. Time is very short. And I use the phrase last day specifically because the phrase end of life, really there's no standard definition of what that phrase means. In some definitions it's sort of the last year of life, which doesn't really make sense. So last days, professionals and the general public can be clear what last days means. It's a good phrase to use. And a care plan. Now, this could be called a template or a pro forma or a care bundle. It could be an assessment tool, a daily review. Really, the document's name and its associated semantics are secondary, okay? So what would really happen? To initiate the template, the multidisciplinary team, along with the patient or the family, come to a consensus that unfortunately the person is in their last days. The time is very likely to be short. Nothing is definite, but we use those words likely. Time is very likely to be short. And the priority at this point is for comfort and a natural death, okay? Again, remember, we're in hospitals where the majority of deaths take place. So now we're in hospital. The healthcare documentation in hospital is in Compass. It's all computerised on Compass. So the doctor or nurse would pull up this documentation and it would start something like, and this isn't written, but it would start something like, people present in room, and a space to put the details. Patient goals of care, and a space to document. Prompt to ask if the patient wishes to die at home, and a prompt to guide a conversation about the practicalities of that. A prompt to review the previous medications, so perhaps some medication that the patient can no longer take orally but needs to be replaced in a patch or in an injection or through a syringe pump. And I suppose those prompts are specifically related to anti-seizure medicines or Parkinson's disease medicines, previous anti-sickness drugs or analgesics they were on. There's a certain range of drugs that are useful to replace for the patient if they cannot swallow for themselves. A prompt to ask if the patient is a previous smoker, because if they are, is it worth putting a nicotine patch on so they don't experience any cravings at a time that they're not fit to go outside to smoke a cigarette? A prompt to check that the not for resuscitation order is signed, a prompt to make sure there's that natural death that will occur. A prompt to ask the nursing staff specifically about symptoms, and a prompt to ask the families specifically of the symptoms they've seen in the past 24 hours. A prompt to ask the patient if they're well enough, but patients, as I say, at this is very much the final hours and days, may not be fit to respond. A prompt to look and examine the chart for the number of extra medications a patient is required and whether these have been helpful for the patient. A prompt to ask about spiritual importance. So a prompt to say, is this person religious? Did they have a faith? Or did they have non-religious meanings of hope and meaning in their life? And a prompt then to encourage either the use of the hospital chaplain or their own spiritual leader or something along those lines. A prompt to ask specifically about the cultural needs at this time. There's no crime in not knowing every culture's needs, but there is an asking, not asking. A prompt to ask specifically about the emotional state of the patient and their family. Prompt to look at mouth care. A prompt to assess for hydration and encourage oral fluids and food for taste and pleasure, if that's possible, or consider other aspects of hydration. And really planned prompts to think about that mouth care again. Think about whether the medication is the right ones. Think about whether there's anything that we are doing that is unhelpful to the patient or anything more that we should be doing that would be helpful. I don't think this is controversial. I don't understand how anyone would see these prompts as controversial. This is to guide individualised care. The prompts ask the questions, and there is a structure to asking those questions because the questions are physical, spiritual, psychological, and social questions, and those can be structured. The response is individual, and the response guides that personal care and gives a voice to the patient and their family. So really, this is to ask the right questions, okay? I've shared with you a teaching tool that we teach the F2 doctors, so second year doctors, and we teach. A lot of what I've said is based on this teaching tool as well. I just want to be very clear and very transparent with you. This is all open for anyone to see. This would be put through multiple patient and user groups before it was in place. And I just want to show you that this is very transparent, but it is not just hand-holding and being nice and smiling. These are very specific things that are required to help in those last days. So I would respectfully ask the opportunity to speak directly to those that are advising the minister in the department, because I do wonder whether a multidisciplinary team of doctors, nurses, pharmacists speaking to those advising the minister would be able to clarify a lot of the issues brought up in the response. We would want to be there with users, with the members of the general public. We would want to bring a draft template for discussion to really show what that would look like. And I think we could answer a lot of the concerns that they highlighted with speaking about this openly. So for your continued interest, thank you, and I'll pass on to my colleagues, Macmillan.
Thank you so much. Chair, members of the committee, thank you for the invitation to speak today. Macmillan supports people living with cancer to live well and to die with dignity. Today, I will outline 5 key priorities that build on what Dr. Cousins has said as well. At the heart of this are people. It's the population that we serve. So, with our priorities that we've shaped by our professionals and people living with cancer, this is not the opinion of Macmillan, it's the people that are on the front line, it's the people receiving the treatment. It's grounded in our written evidence and building on the themes from previous sessions that you've heard. We believe these priorities, alongside other recommendations, will help transform palliative care. They are equitable service delivery, advanced care planning, community-based specialist teams, workforce leadership and stability, and prehabilitation. We'll start with tackling regional inequity. Across Northern Ireland's 5 health and social care trusts, we see significant variation in what palliative services are available. In the national audit of care at the end of life, 4 of the 5 trusts reported using advanced care planning processes, but their infrastructure, recording systems and team composition differ widely, leading to a postcode lottery of care quality and outcomes. Patients in one trust may receive community physiotherapy and dietitian support. In another, such services are absent. We know there are huge variations in access to community specialist palliative care teams across trusts. We also know that a lot of the support required by people at palliative and end of life is delivered by our allied health professionals. Still, the AHP workforce hasn't grown in the last 20 years. We urge the committee to recommend a streamlined regional framework, which feeds into what Dr. Cousins has been saying, setting minimum standards for each trust and ensuring a parity of specialist services, medicine access and support teams. Next, it's embedding advanced care planning. Advanced care planning is not a one-off form or conversation, but a process that gives patients control over future decisions, where they wish to be cared for, what treatment they want or, importantly, refuse, and who should speak on their behalf should they lack capacity. When done well, advanced care planning reduces emergency admissions and ensures wishes are honoured. A daughter recalled, "Because we had documented Mum's wish to stay at home, when her breathing worsened, we, Mum included, understood what was happening due to breath management training from the specialist team. The paramedics didn't take her to A&E, they followed the plan, and she died peacefully in her favourite room. We cannot underestimate the difference that made." We welcome Diane Dodd's MLA's calls for a clinical lead for palliative care. Such a role, backed by clear metrics, would drive advanced care planning rollout, audit uptake and continuous improvement across all trusts and provide oversight of the whole system. Next, we have elevating community specialist teams and AHP representation. Community teams, nurse specialists, allied health professionals, such as our physios, our occupational therapy, dietitians and social workers, are at the front line in preventing traumatic A&E admissions. Yet none of the inquiry sessions has included formal AHP testimony. Their voices are vital. They work on the front line and bring extremely powerful insights. We'd like to recommend that the committee meet with the community specialist palliative teams to hear how rapid response visits, home-based breath management and social support avert crisis. Including AHP representation will ensure that policy reflects the full spectrum of care providers. Next, we have securing and stabilising the workforce. This is nothing new. We all know the issues that our workforce face. They're not just a UK and Ireland issue, they are a global issue. Too many key palliative roles are funded by charities and deemed at risk year to year. This precarious model undermines service continuity, and as charities, we're at risk of masking the gaps in services by propping up these services and absorbing risk and harm that no one else will. Macmillan calls for core funding of specialist nurses, allied health professionals and therapist posts within the HSC budget. Mandatory palliative care training for all primary, secondary and community staff so that every clinician feels empowered in identifying needs and initiating advanced care plan discussions. Only with trained permanent teams can we guarantee 24/7 support and avoid the distress of service withdrawals. Finally, we have introducing prehab. Beyond crisis care, we must help people live as well as possible before an advanced decline. Prehabilitation such as breath management programs, targeted physiotherapy and diet optimisation can strengthen resilience, reduce symptom burden and delay hospitalisation. Evidence from pilot services show prehab can improve the quality of life and reduce costs, yet it remains rare here. In summary, NI has the ambition and compassion to lead in palliative care, but we need regional standards to end the postcode lottery, a clinical lead to drive advanced care planning as standard practice, allied healthcare professionals and community team voices in this inquiry and future policy making, secured funding for specialist roles and training, and prehabilitation services embedded in care pathways. I thank the committee for your time. We must work in collaboration to make these priorities a reality so that every person facing serious illness in NI receives the dignity, control and support that they wholeheartedly deserve. I'll now hand over to Christine, who I know will provide you a very powerful testimony. Thank you.
Thank you, Sarah, and thank you, Sarah and Sarah. I've been here before in another capacity, but thank you for inviting me today. I am a palliative care patient, and I have been since April 21. And you maybe think to yourself, well, how could you be a palliative care patient from April 21? It's now almost July 25. But I had a stage 4B high-grade serious ovarian cancer diagnosis in April 21. And that was a result of an emergency admission to the Ulster Hospital here. Palliative care, what does that mean? I think people have different ideas of what palliative care means. A lot of people will assume palliative care is end-of-life care, but that's not necessarily so. There is that differentiation, as Sarah mentioned earlier. But what is palliative care actually to me? Palliative care to me is me living my best life with cancer, living well through my pain management, through my treatment management, and having a holistic approach to what it is that I need for my overall well-being, really, going beyond what is my physical symptoms. So Sarah talked about psychological needs, emotional needs, financial needs, all those sorts of things. And really, palliative care to me it's part of my human right. Sometimes this is difficult to talk about, but Sarah was talking about advanced care needs, advanced care planning. I was initially diagnosed in April 21. I've had chemotherapy, I've had debulking surgery, I've had access to PARP inhibitors, which did help to manage my symptoms. But then they stopped working. And in July 23, I was given a terminal diagnosis of less than 12 months. You can understand how I felt at that time, those emotions that are going through my head. I have family, brothers, sisters, children, etc. How was I going to break the news to them? Everything was going through my head. I just couldn't process anything. And I spoke to the district nurse who came out to me, and I said to her, I would like to do some advanced care planning. What do I need to do? Who do I need to speak to about this? And she turned around and said to me, oh, you don't need to worry about that. I'll deal with that and your GP. We'll make those decisions about end-of-life care. But what if I don't want to go into hospital? I don't want medical intervention. I want to be at home. Oh, no, we'll sort that out. So it was denying me as a patient control over how I was living, but also how I was going to die. I've had a lot of issues around palliative care. I've had some really good experiences, and Sarah was saying the things that are in place at the minute from a medical point of view, also from a support point of view through Macmillan's cancer support, etc. But there's times as if I felt that I'm battling against the system. I've really bad problems getting access to my GP. The usual phone at 8:30 in the morning, can't get through. Then when you eventually get through, no, there's no appointments. When I was given my terminal diagnosis in July 23, I was given it on a Monday morning. I really struggled on the Monday. I didn't sleep at all. Tuesday, I got up at 8:30 and I phoned the surgery and I said, I really need to speak to the GP. I'm in a real mental struggle at the moment. And I was told there was no appointments. And I said, look, I really need to speak to somebody now. Phone back at 8:30 tomorrow was the answer. So I get in my car and I drove to my GP. I went to the reception. I was in quite a state, and I did explain to them that I really needed to speak to somebody now, and they could see how distressed I was. And they said, look, we don't have any appointments. You were told on the phone to phone at 8:30. And I said, no, I need to speak to somebody. No, they refused to let me see the GP. I came out of the doctor's surgery. I thought my legs were going to go from underneath me, and got in the car and sat and cried. And I thought, is there nobody there that's going to help me? I then eventually got an appointment after my sister phoned up and was quite vocal, let's say, to the practice manager and the GPs. And I eventually got speaking to the GP. And the first thing she said to me, without even listening to what I had to say, was, "Your sister's quite aggressive, isn't she? I need to think of my receptionist staff and protect their mental health." And I said, "Well, I'm really sorry, but I'm more concerned about my mental health." When I eventually said to her what had happened the day before getting my terminal diagnosis, she did then apologise to me, but the damage was done by then. I've also had issues getting access to my acute meds. I've taken numerous blood clots over the last couple of years, and when I've been discharged from hospital, you'll get I probably know the name for it, it's like a prescription from the hospital, you leave it into your GP. When I left it into my GP's, I'd been given enough anti-clotting injections for a week and was told that the GP would issue me with my prescription going forward. So 7 days were up, I still hadn't heard from my GP. I phoned and spoke to them, and they said to me, "Oh, you're not allowed to access to acute meds unless you have a doctor's appointment." And I said, "Well, could someone have told me that?" And they couldn't give me an answer. So in the end, I eventually got an appointment with the GP the day after. So I'd missed one dose of my anti-clotting meds. So the day after, I did get an appointment with the GP, and I sat down and I explained to him, "Look, these were acute meds, it was a prescription. These are life-saving drugs to me at this moment in time." And I was told, "Well, you do need to see the GP." And I said, "Can you tell me where on your website or any of the information that you have available to your patients that this has to be done, this process has to be done this way?" And he said, "No, there isn't." So I was able to effect change in a way, because going forward then they listened to what I had to say, and there is now advice on the front page of the website, on the home page of the website, saying, if you need your acute meds, this is the process that you need to follow. So anybody coming behind me hopefully will not have to experience what I had to experience fighting to get access to my acute meds. Holistic needs assessments. We all need holistic needs assessments. Anybody with a terminal diagnosis, because as Sarah said, it's not just the treatment side of things. You need to be looking at what patients need, what those people need at that particular point in time, whether it's emotional needs, etc. One thing that Sarah didn't mention, and I'm going to raise this, and my daughter's in the room, so hopefully she's not cringing with embarrassment, but I actually went to my GP. I'd had full debulking surgery, etc. I'd been through the menopause, etc. But I still got a pulse. I'm still interested in sex, I'm not embarrassed to say. And I said to the doctor, I'm having real issues here. Is there somewhere that you could actually refer me to? Because that was one of my unmet needs. And the first thing he said to me was, "Oh, you're still having sex?" And I thought, right, okay. Maybe I'm abnormal, I don't know, but we were able to have that conversation. The advanced care planning does enable you to look at everything that you think that you will need, and also what the professionals, you may have unmet needs, but the professionals are in a place to sort of advise you as well and to guide you in that documentation. Things around, I didn't know the difference between a do not resuscitate and a right to refuse treatment. I didn't really fully understand. So there needs to be a piece of information and communication to those people that are in palliative care. What does that look like? You know, information around those terms, because as soon as somebody said to me palliative care, my first thought was, I'm dead, I'm dying, I'm not getting out of hospital, and nobody actually sat down and explained to me what it was, what it entailed. I had to go and find that information out for myself. And within Belfast Trust, there's only one CNS who's a clinical nurse specialist around ovarian and gynae cancers. She carries out holistic needs assessments on patients, but you have to request it. It isn't done automatically. You get a list, and it's quite a comprehensive list of things that you think you may need going forward. Things like counselling, access to maybe a welfare, a benefits advisor, all those sorts of things. So you have to tick 10. So that's the normal. You tick 10 of these boxes, and this is what you're allocated, like half an hour to talk about what your needs are. So that was fine. We filled out the form, and then she said to me, "I'm really sorry, I'm very busy, but I can only talk over 3 of these with you." I went, "Well, why are you wasting my time asking me to think about the 10 things that I..." And then she just handed me information and said, "You need to go and find this out for yourself." Really, what I would like to see coming out of this inquiry is that patients have more control and more autonomy over how their palliative care and their end-of-life care looks like. I don't want someone saying to somebody else, "Leave it up to us, you've no control over this, we will decide for you." I want to decide for myself. I've decided how I've lived, how I'm living. I'm living beyond cancer, thankfully, at the moment. But I also want to have a sense of control over how I die, where I die, how I die, etc. So I want to see more flexibility around the pathways and criteria that enable you to access palliative care services when and where they are needed. So, as Sarah said earlier, to avoid people having to go into hospital through the A&E, that's not acceptable. It's not acceptable. My time is precious. I don't want to be sitting in an A&E bed for 24 hours or whatever it happens to be. That time is precious to me. I would like to see less fragmented communications between a range of professionals, because there is so many professionals involved in palliative care, from physios, doctors, consultants, etc. There needs to be less fragmented communication between them all, because it's very confusing. It is very confusing. I would love to go to one particular point and say, "Right, you're my key person. What do I need to do? Who do I need to refer to for this? Who do I need to refer to for that?" And really the need to push a key worker. I've now found out my key worker is my district nurse, and I'm now 4 years down the line in my palliative care. I must admit she is very good, and she's there to coordinate any care or support and keep me informed, really. But that's not accessible to everybody across every trust. There should be consistency so that everyone has access to that key worker going forward. And a big thing for me is palliative care does not end at 5 o'clock on a Friday afternoon. It's just unacceptable. 5 o'clock and bank holidays, the number of times my treatment stops. I get weekly treatment, but I don't get weekly treatment on a bank holiday Monday because it's stopped, because everybody's off. And that does affect me psychologically, in that, what if I don't get this treatment today? Because it's weekly treatment, what effect is that going to have on me? Is that going to give me 1 month less, 6 months less, because I've missed one treatment? So it's that mental turmoil that actually goes around that. So I really think that there should be something there that maybe we should look to extend the funding of how palliative care is delivered in the community, and that more compassionate side of it in that we all have a right. We all have a role to play. But don't tell me that that role and responsibility and that support stops at 5 p.m. on a Friday afternoon. Thank you.
Thank you. Thank you all. I always say to the witnesses during the inquiry, probably at the end, that I hope that what we're doing does justice to the evidence that we hear from your perspective, Christine, from our perspective, listening to you. I think it's absolutely key that we try to do justice to some of the things that we heard earlier on today, informally from families who have had loved ones go through the palliative and end of care experience. We hear some positive things, but it's particularly important when we hear the negative things that we try and use this as an opportunity to fix. So I have no questions for you, Christine, but I really do thank you for coming before us today and sharing your experiences. Dr. Cousins, in terms of your contribution, so I was going to ask you, prior to you giving evidence, I kind of jotted down about, were you reassured from the department's response? But obviously that's a stupid question to ask. So, the department are saying the minister is saying there is currently no definitive data or research to suggest the use of a template would improve the care provided to the dying person and to those important to them. I find that a bit of a bizarre.
Well, in its coldest form, what study could you possibly do that would prove that? In the same way that, you shouldn't really need to remind a surgeon when they're operating to remove swabs and instruments from the patient's body. The surgical scrub nurse will still do a checklist and still count those in and out. There are common sense safety mechanisms that we put in healthcare, because sometimes it's 3 a.m, sometimes somebody's just back off maternity leave, sometimes someone's just transferred in from a non-Northern Ireland country, because life happens. So really what evidence I could provide would be tricky. What I will say is looking at, NACEL, the National Audit of Clinical Accidents, so that looks at hospital deaths only, and that has been changed and is reconfigured this year. So this year they are specifically asking the question, does your trust have a individualised care plan template, or is it just that in the notes it appears to be in some way individualised, or there's no template and it's not individualised? Now, I am one of those people who sit trying to mark those and to make that value judgment, and I have to say it's very hard to make those value judgments. But what I understand is that what's coming out early data is suggesting that about 3/4, 75% or more of the hospitals in England and Wales that they've looked at does have this template. So this has been in place for over 10 years now and is common practice. Safety mechanisms are there to prevent a problem, and it's common sense.
Yeah. And you said in your opening presentation you indicated about the advice that the minister's getting, and you made a suggestion in terms of, what would you ask us to do to go back to the minister?
I don't know how to, or who the right people to speak to this are, and what I would hope for would be a multidisciplinary group of the nurses, pharmacists and doctors are the main ones I can think of for those key last days, with patient representatives, and we would have co-created a template, having looked at the other templates, assessment tools, whatever you wish to call them, from elsewhere, and said that this would be reasonable, this would help in hospitals. Now, we are not saying that there would be some sort of legal requirement that every doctor or nurse use this, but it would be available to them as a tool to use, something helpful, because that would provide the professional with the assurance that they were providing a good standard of care. It is also very useful to provide families with that assurance that an excellent standard of care, a hospice level, if you like, standard of care is being provided in a hospital when home or hospice is not possible.
And Sarah, in terms of you're very clear with regard to asks, and we thank you and appreciate for that. In terms of the barriers that exist in access to service, is there any more detail, or can you provide more detail? how frequently cancer patients are redirected to A&E out of hours, and what factors contribute to it?
Significant issues, and we've touched on them already about even having that advanced care plan. So that's the number one, understanding people's wishes and where they want to be. One of the big things when we talk about those community specialist palliative care teams, when they have those interventions with those dietitians, for example, that can stop the spikes in dehydration, which is a main cause of ending up in A&E. It's also the fact of pain management as well. Like, the access to medication is a huge issue, and quite recently a colleague of mine who is terminally unwell, sadly, they were trying to access their pain meds, and they were getting their pain meds every 6 days. They phoned their GP, and Christine's already alluded to the issues with primary care. They phoned their GP after that first 6 days to say, I'm going to run out of medication, I'm in an awful lot of pain. Was reassured that the medication would be there that afternoon. It was a Wednesday, your medication will be there. His sister went down, that GP surgery was closed.
So I said I wasn't going to ask Christine a question, and I'm maybe not even ask it to her, but when she was talking, I was finding it a bit bizarre, and I don't completely understand the system, but I would like to think that if I was being given a terminal illness diagnosis, that one of the very first people instantly being informed about this also would be my GP. I mean, is that not the case? And is that something that should be the case?
Well, I actually had to tell my GP that I had a terminal diagnosis because he hadn't received that information yet. But that was in July 23. With the rollout of Encompass, that may have changed. So I can't speak for this moment in time. I can only speak for... But then again, have all GP surgeries, I'm not sure, adopted Encompass and have access. Yeah. So you can understand how stressful it was for me almost having a breakdown in the doctor's surgery and then having to go in and then tell him, I've been given this terminal diagnosis. This is why I need to speak to you urgently.
I mean, we've had evidence recently from GPs who have told us that, I mean, particularly end of life care, that is their priority. They will drop everything, etc., etc. But I mean, you would expect them to know that information.
I'm laughing, and I shouldn't laugh because this is my life and this is my experience. But I've been told numerous times by my GP that I am red flagged, that I am a priority patient, and I still get the 8:30 in the morning. Don't know, we've no appointments left.
I'm going to leave that there. That's pretty disturbing. Diane?
Thank you very much, Chair, and thank you for the presentation, and particularly Christine. It's never easy really to present, but that's a very powerful one. Couple of things that maybe Christine, I do think it's worth, sorry to plague you, but I do think it is worth actually just focusing on. Earlier today we heard from people who'd had recent experience of palliative care and how it works, and it seems to me it's a bit, unfortunately, a little bit like much of the health service, where you have to go searching for information rather than, because you think when you're given this awful diagnosis that everybody's going to come out of the woodwork and you're going to be swamped with information and help. Today's testimonies tell us something very, very different. And they also tell us, and I know you're speaking specifically about end of care and those kind of life plans, but it also tells us the need for some kind of coordination and information for patients as they go through this journey. And maybe you want to maybe say a little bit more about that, because I do think it's not necessarily for those who have the terminal diagnosis and are facing a very immediate issue, but it's also for those who are on that journey, and that journey can, as you say, it can last whatever long it lasts,
I do think communication and information is key in advising people and giving them choices, because it's that old cliche, you don't know what you don't know. through my experiences, I'm quite vocal in when I'm speaking to maybe women's groups, telling them about ovarian cancer, raising awareness of that, etc. You know, I will be telling them about how they can access, say, the WIG service or access counselling, things like that, just things that you maybe didn't. One of the really key things that, this is so simple, access to a radar key. And a radar key gives you access to disabled toilets. And the number of people that I speak to that don't know anything about that, and that's very important for somebody that's in palliative care, because with me, I had bowel problems, I had urinary problems and stuff. But having that information and having maybe an information pack that you could give to someone when they've been given that diagnosis, that not everybody wants to know that information, and I can understand why. And it may take people a while to process information, so it's important that they have access to information as and when they need it, whether it's through a website, whether it's through a leaflet, whether it's giving them a number for Macmillan cancer support, etc. So it's having that information there for when they need it. I know myself, I got my diagnosis in July 23, my terminal diagnosis. I was given treatment to manage my symptoms and the pain. It finished in February 24. I went and I had an appointment with my oncologist where she basically said to me, there's nothing else we can do. Well, not, I'm being very bland. You know, I was put much more, let's say, it's delivered better than what I'm delivering it to you, sorry. But she, more or less, there was nothing else that they could do. And I came out of the room and there was not one single person outside that room that I could talk to or made contact with me. So there is this like disconnect, this in how the service is delivered. It's not always consistent. I know there's people who've had really good experience, and there's parts of the palliative care that I will say, yes, I've had a good experience. But it's those issues that I want to see addressed, and information is key. Giving that people information as and when they need it. What does palliative care look like? What is it that you can do to empower yourself that you want to see happen? How do you engage? You know, sometimes it's medical professionals talking at you,
Yes.
not talking to you or getting your opinions. So, no disrespect.
I'm sorry. I'm sorry.
Sarah.
I feel like I need to apologise.
I'm just saying sometimes
professionals.
it comes across as that it's as if you're
I
being
know.
spoken to, rather than someone taking into account what you feel. So if you have that information there that you can, as and when you need it, can go, yes, I can contact Macmillan or I can contact such and such. They might be able to give me a bit more information. And it's removing that stigma as well around what does palliative care and end-of-life care mean? Because as soon as somebody said to me palliative care, I thought, I'm not getting out of this hospital. That's it. That's just the thought that went through my head. So it's an information piece around as well. What is palliative care? How does the differentiation between that and end-of-life care?
It's very powerful, and I suppose for all of us to remember that we're talking to a person, not a disease, and that's a really, really powerful point that you make. And we could all benefit, not just clinicians, we could all benefit from remembering that point. It is very powerful. The only last thing I want to talk about, because I have a being want about this, and I've talked about it many times, is this issue of regional inequality. And I do think that there is a really big problem in Northern Ireland. We're a very small population, less than 2 million people, but we deliver things so differently. So we may be able to deliver emergency drugs in one trust differently to another trust, and so on. And so I mean, that's why the planning that you're talking about, I think is quite important. But also I think it's also important that we are forcing the minister and the trusts to adopt a policy where no matter where you are, whether that's in, I don't know, Coleraine or it's in Banbridge that you actually can expect something of the same kind of care delivery. And I think maybe more a comment than anything else, I think that is one of the issues that our inquiry really needs to focus on. And how do we make the department responsible for that coordination? So I don't know whether you have any comments on that or not, but I think it's really poor in Northern Ireland that we don't have that.
I don't know why it's not a priority for the department to improve standards regionally. I suppose if I'm thinking specifically about this last day's documentation, is there a concern about what the general public would think? Is there a fear? I mean, I personally find that the general public, and Christine, you are an example, are very pragmatic and sensible about the realities of life and death. And I wonder, is there a fear that they could not, that the public would in some way not understand a regional approach or standardising care, which is just not true, I believe.
Can I just jump in there? I think if the basics are there across all trusts, then it can be built on. But sometimes each trust has its own interpretation of what the basic need is. And I think there needs to be some sort of documentation of written down, not policy or anything, but something to say, this is the basic need. This, yes, standard, exactly. Sorry, you had the words, I didn't. There should be a standard, and that each trust can build on that standard depending on the needs of the population within that area.
I jotted down when Sarah was talking her contribution. She said there should be minimum standards. I think that's what we're asking for. And the minimum standards should be pretty high. Okay, thank you, Danny.
Thank you, Chair, and thanks to all three of you for your presentations. All very powerful. I declare an interest as a nurse who has delivered palliative care for many years in the Ulster Hospital, and certainly I'm familiar with all the issues that you raise, and certainly we want to deliver, and I know everybody who works in the health service wants to deliver the best palliative care they can, and they want the patient and the family to be as comfortable in those last few days as possible. It did strike me, Dr. Cousins, that what you were saying about this standardised approach is like an update of the Liverpool care pathway plan that we used to have and then was got rid of. And it, for some of its problems, it did work because it had that standardised approach. Everybody was familiar with it. And that's the sort of thing that we do need. We use it for lots of other conditions, GMOS, MUST, Braden. You know, there are tools that nurses are all familiar with. They're all regionalised, they're all standardised, and it makes sure that nothing is missed. You know, there's nothing omitted. When you go through a checklist and you go through everything, nothing can be omitted then. And I think that's very, very important in this particular situation. So certainly I think it's something that we absolutely should.
The Liverpool care pathway did have some problems, and I can list them out for you. It had a problem with its name because it implied that once you were on this documentation that you didn't come off, and we know that that's not true, but it certainly, the name did not help, and maybe I alluded to something of the semantics. What we would be proposing would be something that would be useful if it appears like the last days is likely the situation that the patient is unfortunately in, but it is none of what I said was fixed or definitive in any way. Condition improves, re-evaluation and hopefully recovery. The other problems with the Liverpool care pathway was a specific misunderstanding regarding food and fluids. So very much now the advice from our dietetic colleagues and our speech and language colleagues are food and fluids for taste and pleasure and for enjoyment. If the swallow is poor and someone is at a very low ebb or very weak in those last days, to have that for pleasure. It is also, there's a lot more evidence about perhaps the role of drips, of of artificial fluid in managing perhaps delirium. There's just a lot more evidence 10 years on that we have at our disposal that would avoid a lot of the problems that they had. And I think the third thing was in terms of training. So 15 years ago, it was nearly unheard of to have all your training and your education online in a standardised package across an entire region. Now it's standard, so it's everything. It's haemovigilance, it's your blood safety, it's your infection control, it's more or less every regional aspect of training and teaching is provided by HSC Learn, and it is very standard to create an interactive learning platform where your staff will go at the time of their convenience in order to go through. There's tests, there's videos, there's all sorts of things embedded in them, and then receive a certificate of completion of the training. That was unheard of 15 years ago. So there's some of the comments that were made by the department. The challenges, they're not there anymore, but those are the finer details that can be discussed. It is very much, this has been used in England and Wales in various forms for over 10 years now with great success. So perhaps the department are not aware of that updated information, and they're working on more outdated data.
I can certainly attest to the training regime having changed dramatically. And sat in front of computers for hours, doing those courses. And yes, everybody does the same one, and we're all familiar with the same processes. And a lot of the things are being done, and a lot of the doctors, when somebody gets put onto comfort care, when comfort care is documented in the notes, then that there will be, but there's no standardised programme, and that's the thing.
And it relies on the clinician's experience, and they may just have been qualified, or they may be working in a ward that's doesn't see as many deaths as other wards, because of course not all deaths occur in different wards individually equally. So really it is to make sure that it's standardised between wards, between hospitals, that wherever you find yourself in hospital, you can attest to, you know what, somebody in a hospice has gone through and looked at this and said, yes, this would elevate this up to more towards that hospice level of care which we're aiming for on our wards.
With that, can I ask just about the difference that is between a patient and a family? What would that make to the patient and the family?
The patient and the family in terms of a template. We want this care to be individualised and personalised, but to do that, we need to give the patient and family a voice. So we need to ask the right questions. So that is why we use these templates, to ask the right questions. So, as I said, the questions are fairly standard regarding physical, social, sexual, spiritual and emotional needs. But it's the answers coming back that's personal. This is equivalent to at the other end of life, at a birth plan, for example, at those early days of life. That is individual, that is unique. Women have their very specific birth plan. But are you trying to tell me that we should discard the midwife's templates to check for domestic violence in the house and all of the other checklists that they do? Are you telling me that caesarean section checklists in theatre should be abandoned because we want to focus on individual and personal care? Of course we want individual and personal care, but we need to give the patients and family a voice. Very often, and Christine is perhaps unusual, but families and patients will not volunteer until they are asked. So recently I was asking, a husband, well, does your wife, are they religious? Is it important to them? Do they have a faith? No. And there was a pause. And you can choose to jump in a pause, as you will know, or you can choose to wait. So I chose to wait. Crystals. It was crystals for her. So she said that if she was awake and alert, she would have crystals everywhere. This was a huge source of comfort. So then you start to bring in, well, it doesn't always have to be about religion, but bringing in sources of hope. But if you don't ask the question, would that husband have felt encouraged to phone up his sister and ask them to bring the crystals in, to put them in her hand and have that comfort? No, because this is healthcare, this is authority, this is an unusual and an alien environment for people. This is to give people a voice, but we do it through the process of asking and directing others to ask through a template.
Thank you very much for that. Can I just say as well, Christine, I've heard you speak several times over the years, and it's always incredibly powerful. You're a huge advocate. Especially at this time, so I really think it's fantastic. Thank you.
Can I ask a question? Is it okay? Danny, you were saying you come from palliative care sort of background. Is there formal training for those who participate from a medical side in palliative care? Is there like formal training like an MVQ, or is there specialised training for you, or is that a role that you sort of grow into and something that you've been interested in and therefore take forward? Is there professionalised qualifications for palliative care?
There is specialised qualifications you can move on. My background is nursing, and I've worked in a lot of hospital wards where people have terminal conditions and passed away and been through palliative care, delivered palliative care. There is palliative care nurse, which is a specialised designation that you can do extra training and go on and do that. And they're amazing. You know, they really are fantastic. And when they come and assess a patient on the ward, the comfort that they bring to the patient and the family is phenomenal, and highly valued. Their expertise and their knowledge is incredibly valued across.
Thank you for that. Thank you.
Alan? Thanks, Chair, and thank you all for your presentation. Christine, I've always said in here, and I've said it in the chamber on multiple times, that people's personal testimonies always add value, and you certainly have added value to our inquiry here today, as of those earlier this morning who we met. Can I also just say to Dr. Cousins, I found that you are a breath of fresh air. There are some times that we have people within the health sector that come to this room and that session, you can see that there is a reluctance to volunteer ideas and fear in case they are in contention in some cases with the department. So we very much value that, and I think
maybe they're wiser.
maybe no, I would dispute that. I just think that there's a slight irony, and just on Diane had made a comment there about regional inequalities, and here we are on the 12th of June 2024, exactly a year ago, where the Minister was talking about one of his priority areas was regional inequalities, and here you are proposing something that would help to address that. So there is an irony in the Minister on one hand telling us of his priorities, on the other hand giving us a response like that.
Thank you. So, thank you very much. That was really appreciative, and we do, as I say earlier, hope we can do justice to all the evidence that we have heard. So, thank you.
Thanks so much. Thank you. Thanks.
Okay, members. Item number 6 is an oral briefing from Belfast Health and Social Care Trust on the review of the RVH cardiac unit. So, can I refer members to the written ministerial statement at page 30, and correspondence with Belfast Trust is page 6 in the table of papers. So, I'm just Maureen, Ciaran. Are they out there? Okay.
You always need it for a health committee.
She left. So can I just welcome Ciaran Mulgrew, Chairperson, Maureen Edwards, Interim Chief Executive, Chris Hagan, Medical Director, and Tara Clinton, who's the Interim Director of Anaesthetics, Critical Care, Theatres and Surgery. So thank you very much for coming to committee today. So I'm just going to allow you to give us a bit of a, I mean, if you want, some introductory remarks, and then we're going to take questions from members.
Thank you, Philip. Do I need to press a button here?
No. Just
it's
fire away.
working.
Speak in, the mic will pick you up.
Thank you. Now, so you've introduced us all, so I just want to say at the outset that we were happy to get the invitation to come here today. Since the independent review was reported, since the team came back to us, there's been a lot of comment about the cardiac surgery unit and the Belfast Trust in general. Not all of that has been accurate, and we're pleased to get the opportunity here to discuss things. The good news is that the independent review team found the service to be safe, and that's the number one priority. The reality is that there were some appalling behaviours referred to, and there's no point in not being open and frank about that, and Maureen will go into that in more detail in a moment. But we're here today to be publicly accountable for the actions of the Belfast Trust with regard to the issues around the cardiac unit. And we need to be accountable to the 650,000 people who live within the Belfast Trust area, and to the 1.9 million people who live within Northern Ireland who rely on the cardiac surgery unit for a regional service. We have highly skilled surgeons, all of whom remain in work and continue to perform surgeries through what has been a difficult period for them, and they're to be commended for that, as are all of the other clinical and non-clinical staff who continue to put their patients first across the cardiac unit and across the trust in general. Our clinical outcomes are top class. We have patient satisfaction scores regularly at 99 and 100% patient satisfaction. So if any of us are unfortunate enough to require cardiac surgery this evening, the best place that you could go to get it is in the cardiac surgery unit within the Belfast Trust. You would be lucky to be brought there versus any other unit on the island of Ireland or in the British Isles. But we're here to, as I said, to reassure the public, and we've got 23,000 members of the public who work within the Belfast Trust, and they deserve to be reassured that the organisation learns from issues, that we try to create a working culture where people are not just free but are encouraged to speak up, and they'll not be penalised for doing so. And the fact that 70 of our staff were willing to come forward and speak to the independent review, that's a sign that we've made progress in that area, because in the past that did not happen. So I'll pass over to our Trust Chief Executive, Maureen.
Thank you. Now, just, I suppose, for a bit more context on the discussions today. So you'll know that an independent external review was commissioned by the PHA and SPPG in early 25, and that was following concerns with the PHA primarily around the safety of the cardiac surgery unit. The team of very experienced reviewers in the UK who have done a number of similar reviews, including a number of reviews in cardiac surgery units, began their work in early February with two principal aims. So the first was to examine processes, governance and outcomes to provide assurance that the cardiac surgery service is safe. And secondly, to look at culture, teamwork and behaviours and recommend any additional actions that would facilitate high performance within the service. With regards to the culture piece, this was not an investigation or an inspection. What the review team and what they told us they aimed to do was to get a temperature check of staff feelings and experience of any concerns they had and fears at a moment in time. They had, as Ciaran said, they had planned to meet around 20, and we, in discussions with them, agreed to extend the period of the duration of the review to allow them to speak to, a lot of people then put themselves forward, and that allowed them to speak to 70 staff, and it was important for us that we heard as many voices as possible. And I think that also reflects the confidence that the staff had in the process that we'd all agreed to, and the fact that they believed that there would be action. The report was issued to the Trust on the 12th of May, and we had an extraordinary Trust Board on the 15th of May, and the review team came over from England to present their findings. The headlines, as Ciaran said, in terms of safety, our data indicates that the service is safe and that patients receive a quality service. Our NICOR data, which is the cardiac surgery outcomes data, was exemplary, the review panel said. They told Trust Board that day that we have a wonderful staff and that our patients get a great service, and that would be consistent with the patient experience feedback that we get and the many compliments that the cardiac service receives. However, and this is why we're here today, they also told us that the majority of staff they spoke to expressed significant concerns around culture and teamwork, and they did caution, and we fully accept, that whilst we currently have a safe, high quality service, and that is undisputed, cultural issues if left unresolved do pose a risk to patients and the quality over time. The report concluded that Belfast Trust has world-class cardiac surgery premises, and we've done a lot of work since the RCS in that space, and that we'd made good progress on many of the RCS report recommendations despite the disruption caused by COVID, which impacted on our ability to bring forward at pace the cultural issues, and the team noted that those achievements were testament to management in the unit. However, and again, this is the most important outcome, they concluded that cultural issues and poor behaviours in the cardiac unit have persisted for some time and are still prevalent. And in getting to the nub of what those poor behaviours are, the review team were very clear that a pattern of behaviours in a part of a very small number of cardiac surgeons. Those few consultants were causing discomfort and distress, and too many staff, and in particular, we heard junior medical and nursing staff, felt unsafe, felt fearful of raising points of concern regarding practice and behaviours. They included in the report a number of direct quotes, the most powerful of which you will have heard in the media over the last few weeks. We at Trust Board discussed the review's findings and recommendations in some detail, and we have fully accepted all of the recommendations. There was an overwhelming sense of shame at Trust Board, particularly around the fact that staff in our unit do not feel safe to raise concerns, which we know, if unaddressed, poses a risk to those in our care. And I should say at this point that the Trust was aware of and was addressing disputes and poor behaviours in the cardiac unit, and we had a number of HR and legal processes ongoing. However, the evidence suggested that those issues were confined to and impacting on a small number of surgeons and a few related staff. We were not aware of the significant impact the behaviours of these few staff were having on the wider team and the distress that this was causing them, which has obviously now become evident in the report. Trust Board, as you would expect, were shocked, appalled at the behaviours of some of our staff, and we are sorry that we have not been able to address the issues. Normally with external reviews in this trust and in other trusts, the full report would not be shared beyond management level, and only high level findings and recommendations would normally be shared with wider teams. However, given that this itself was a criticism in the report, given our desire and the work we're doing around open, just and learning culture, our desire to be as open and transparent with a group of staff who we recognise had given up considerable time to feed into this review, and of course the severity of the issues highlighted, we took the decision as Trust Board to share the full unredacted report with all of the staff in the cardiac surgery unit who wished to see it. We held 3 town hall meetings, we call them open forum meetings, the week after Trust Board, and around 150 of our 250 staff attended those meetings. At the meetings, the chairman and I presented the findings and recommendations, and I used almost word for word the presentation that was delivered by the review team in all of its detail. And we outlined the actions that had already been taken and the actions in terms of next steps in implementing all of the recommendations, which obviously are at an early stage, but we shared all that we could, and we asked for any input, so we got some feedback about team building, etc., which we have fed into the action plan. At those meetings, we were absolutely clear with staff that they should not have to train or work in that type of environment that we heard about, and that behaviours such as those would not be tolerated in the future. We have given our strong commitment to them that we will now do whatever we can and as quickly as we can to ensure that staff are not only encouraged but are supported and feel safe to speak up if they have concerns about safety or behaviours, and we can then address those concerns. Following the open question session at those town hall meetings, then each member of staff was given the full unredacted report. In the last few weeks, given the attention this has attracted, we have been asked on various times whether issuing the full report rather than headline messages and recommendations was a good idea. Do I regret the distress caused to our staff in the last few weeks, not just in the cardiac surgery unit but in other services, and the effect that this has had in terms of public confidence to patients and their families at a time at heightened anxiety? Absolutely, we regret the distress it has brought, But hiding from the issues will not solve what has been an ongoing problem. And staff within the cardiac surgery told us at the town hall meetings, and they have told us on many occasions since, that what we have done is a step change. We have broken a cycle that they didn't agree with, and they appreciate what we have done. And they agreed with us, judge us now on how we implement and the actions that we take. We have given a clear commitment. The transparency has brought criticism, and it has been, unfair on the overwhelming majority of staff in our trust, the 22,000 staff who have not and never would behave inappropriately. But we can only truly move on these long-standing issues if we put all of our cards on the table, if we get it all out there, if we fix the problems that have happened, and then we are held to account by those in our trust primarily, and then by external SPPG and department. In giving the full and unredacted recommendations from the report, we are giving staff full sight of what the leadership team has undertaken to do, and they will now be in a position to judge us. A cardiac surgery oversight group, which has trust board representation, has been established, and we have now developed a comprehensive action plan with clear actions, lines of accountability and timescales to ensure that the recommendations, not only of the recent review, but any recommendations from the previous Royal College of Surgery review which have not been implemented in full, are now implemented as quickly as possible. And we're conscious, of course, that changes in culture and sustaining changes in culture take time. We have already had meetings with PHA and SPPG colleague, as well as our trust board, to take on board any comments on our first draft of the plan, and it has now been submitted to the department, SPPG and PHA. The action plan will be updated on a weekly basis by Tara and the oversight group, and we will report formally in progress to trust board and thereafter to PHA and the department every month, and we will be held accountable and are happy to be held accountable for actions and progress. The oversight group will be supported and challenged by the external support recently promised by the Minister, and it's very welcome, and you'll hear from Chris in a minute. We have had external support. We benefit from external support from other trusts who have gone through similar issues in cardiac surgery or other services, and we will learn that will strengthen we believe the supports that are already in place, and hopefully ensure meaningful change at pace. So there have been a lot of questions then over the last few weeks about who knew what and when and why, and why it seems that issues in cardiac surgery that have been known for some time have not been addressed. So I'm going to hand over to Chris, who will take you through a timeline, starting with the issues that gave rise to the Royal College of Surgery report. Thank you.
Thanks, Maureen. Thank you for asking us here today. So this, from our perspective, began in 2019 when some of the team approached the former medical director and myself as the deputy medical director about concerns around bullying within the team, and it transpired that this had been going on for many years within that team. It's an isolated team in some ways. It sits in itself in its own theatre area in the Royal at that time. And at that time, we chose to try and address this issue, and that's why we invited the Royal College of Surgeons to come in January 2020. They gave us verbal feedback in March, and you'll remember in March 20 is when the pandemic started, that the unit was safe, but raised significant issues around culture within the team and poor treatment of trainees. And then we were provided with the report in June 2020, of which there were 37 recommendations. And I'm going to break them down into four main themes. There was cultural issues around bullying and allegations of racism within the unit. There was issues around local leadership and management, and they recommended that required support, and that there were systems and processes within the unit that were somewhat outdated. They suggested that the thoracic unit should be split from the cardiac unit. They made recommendations about the facilities, and they made recommendations about how the pathways for patients through the unit, including the critical care unit, and there was issues raised around financial probity within the team. I met with the team, with the chief executive at that time, and we did a presentation to them in June, sharing the report and also highlighting the concerns in particular around bullying and poor culture, And at that stage, we reminded them of the evidence around incivility and how that can affect patient safety. So there was no doubt within the team of what was expected in terms of their behaviours. At that time, we were aware of one surgeon who was bullying trainees, and he was fully restricted at that point in terms of his dealing with trainees, and he subsequently left the unit. We brought in an outside clinical director to run the unit, who had lots of experience of being a clinical director, and a very senior vascular surgeon also came into the team to support them. And we engaged with the Leadership Centre for mentoring and support. On Friday the 23rd of October, we held what was called a Risk Summit. So a Risk Summit is something where we bring together stakeholders who would have an interest in this unit. So that included Department of Health, Public Health Agency, the board at that time, the NIMDA, the training agency, PPAs, their practitioner performance advice. So they provide external advice to people like me, like medical directors, about management of concerns, the GMC, RQIA and Queen's University. And they supported the Trust's approach in terms of developing the action plan and the management of the concerns, particularly around the treatment of trainees and other staff. They noted at that time that the clinical outcomes were excellent, and that was a main feature of the report, but there was no issues at that time raised in terms of treatment of nursing staff. We then went through a period of multiple disciplinary processes within the team due to the concerns that they were raising against each other, with multiple HR processes. And at the end of it, we were able to recruit 2 new consultant cardiac surgeons into the team due to retirements of 2 individuals. We had an investigation into racism that did not conclude that there was any evidence of racism, and there was a BSO counter-fraud investigation which also did not hold the concerns of fraud. On the 5th of February 2021, we had a second risk summit with exactly the same colleagues, departmental colleagues, PHA, board, NIMDA, GMC, RQIA. And at that point, I and others highlighted the ongoing difficulties of interpersonal relationships within a very small number of the team, which were making it difficult to improve team dynamics. And at that point, NIMDA and the GMC warned us that if the team dynamics didn't improve, they would put the unit into what's called GMC enhanced monitoring for training. And later in February, they did that, which because of their concerns of the environment around trainees. Later in that year, we also began a thing called the staff experience to try and get feedback from our staff to get a sense of what it's like to work in Belfast Trust. And we linked in with Northumbria, who have a lot of expertise in doing that. And this was to get better understanding of how staff felt working in our organisation. We also had an RQIA unannounced inspection into the unit in December 2021. In 2022, we had a further risk summit, the 3rd of January. Again, same partners were present, and it was recorded at that meeting. There was evidence of good progress. 27 of the actions were complete, 9 were underway, and 1 had not started. And it's important to remember this all happened during a pandemic. Okay, so I was the lead for the pandemic response, and I was leading on this response as well. We had consultant listening exercises, trainee listening exercise. We had a new leadership team in place with a new CD, 4 clinical leads, and a new chair of division who sits above that. We managed to separate the cardiac and thoracic team, which was not straightforward because we had surgeons who wanted to continue with mixed practice, and we recruited new consultants. We improved our governance arrangements with things like how we monitored complications in the unit, something that's not done in all cardiac units across the UK because it's not part of the NICOR reporting, and the VLAD reports, which give individual consultant performance, were shared with consultants so that we could monitor individual performance. We also had live monitoring of our waiting lists because at that time, if you remember, there was a lot of patients waiting for surgery, so we were able to identify who most needed surgery. We also learnt lessons from delays in treatment for lung cancer and improved the pathways around that. We audited the wedge resections of lung cancer and showed that there was no issue with that. Our patient experience remained at 98.6%. We managed to relocate the whole unit into a new theatre complex during that time, and by the end of, towards the end of 22, we'd managed to get up to 850 cases per annum. The SBA for the unit is 950, so that's really impressive in the middle of the pandemic to get back up to that. And at that point, no more risk summits were felt necessary due to the progress. Later that year, we also launched the Speak Up for Safety in the Trust, which was encouraging staff to speak up if they had any concerns. In 2023, Peter McBride came into the Trust to do a listening exercise and explore routine openness, and he made a presentation to Trust Board. And then in April of 2023, due to ongoing concerns about poor culture in the cardiac surgical unit, we asked Peter McBride to come in and mediate with the team and work with the team and try again to continue to improve culture. Towards the middle of 24, in July 24, the GMC and NIMDA both recognised that the training experience for trainees had improved significantly, and they took us out of enhanced monitoring. But we were aware that there were continuing to be ongoing cultural issues within the team, amongst what we, as Maureen said, a small number of consultants, and we linked in with a trust in England who had similar problems in their cardiac surgical unit to seek advice, guidance and some linkages, and it was through them that we heard of some of the members of the review team. But at that point they said to us it would take at least 5 years, if not more, to change culture in this unit. And unfortunately, cardiac surgery seems to have difficulty around culture. We're not the only cardiac surgery unit in the UK that has difficulties with culture. I don't need to name them, but you can find it if you go on to the web. The difference between the unit that we were linking with and our own was that their outcomes had suffered because of poor culture. Our outcomes were maintained. As Maureen said, we then commissioned the review with a PHA into the surgical unit. At the time of the review, we also did listening exercises with our trainees, as did the NIMDA, and we identified one individual surgeon who was named by the trainees as bullying them, and we have restricted him from access to trainees also. And we've already talked about the town hall. I think there's a few points that I would like to make also. We've had 2 external reviews of this unit in a 5-year period, and both of them have concluded that the unit is safe with excellent clinical outcomes. And I think that's a really important point that we need to get across. We completely accept that the behaviours of a small number of the team are completely unacceptable, but the unit has made good progress in other areas in terms of getting out of enhanced monitoring. I've met the entire consultant team and reminded them of the importance of their behaviour, and I did a town hall with 200 medical staff yesterday, reminding them also the importance of this. But it is absolutely vital that we retain public confidence in this service. It's absolutely vital. It's an excellent service delivering excellent clinical outcomes, and we need to remind ourselves of that. But it's also important that we don't undermine the confidence in Belfast Trust in its ability to deliver high quality, safe care. We have at least 50 clinical specialties within our organisation that deliver amazing care day in, day out. But unfortunately, the media attention around this affects confidence of staff as well. It's really important that staff feel confident in coming to work, they feel supported, and that we identify the great job that they do. And some of these people will be your constituents. I think it's really important that we acknowledge and recognise that we have a duty of care to our staff as well. And I would offer an open invitation to any one of you to come to our organisation. Come and see what it's like. Come and stand in the emergency department and see what it's like for people working in that environment, or come and see the excellent clinical services, our stroke services, our cardiology services, our surgical services, our paediatric services, our oncology services. Come and see what it's really like. Talk to the staff. It's an open door. There has been some criticism about leadership, and I think that what we have done in terms of sharing this report and being open and transparent about the things we have done is actually leadership in action. We haven't shied away from anything. We've taken these things on and we've tried to fix them. Things don't always work out the way we would have wanted, but we did this in the middle of a pandemic, and I think sometimes people forget this, the efforts we did, and I think we have to celebrate some of the really good things that we did. But we are hands up. There's still an issue with a very small number of surgeons in that unit, and we will try and address that. We have a comprehensive action plan. Our patient feedback remains excellent. The trainees have reported back to me verbally that they notice the environment is improving, which is really great, but there's another listening exercise happening in the next few days, and we're meeting with NIMDA to get an update on their view of what it's like. The GMC have written to the Trust and are not going to put the Trust back into enhanced monitoring because they acknowledge the actions we've taken to date and recognise that they think there's still local measures that we can do to manage this. We've put additional support into the multidisciplinary team meetings because we see that as a particular risk for the service, because that's the place where people come along and are able to discuss complications in a safe way. And if you can't talk about, I'm a surgeon, if you can't talk about your complications in a safe way, then that's unsafe. So we're putting additional support into that. We've also got 2 of the surgeons in that team are in the top 5% of cardiac surgeons in the UK by the NICOR data. Okay, so that's a really important thing for you to understand how good this team is. Since the thoracic team were separated from the cardiac team, they have thrived. They have absolutely thrived. They're innovating. They want to do robotic surgery, and we need to support these people to do these great things for the people of Northern Ireland. There's an issue about instrument throwing in the report. That's under investigation. We have weekly oversight group meeting. We've got mediation and NI working with this team. I don't know if any of you are familiar with them, but they did a lot of work during the Troubles, and they are working with this team, and hopefully we will get some resolution around that. But I need to be open and honest with you and say that some of the surgeons still continue to raise complaints against each other. Despite everything that we've heard, they continue to raise issues against each other. It is really difficult to manage a very small group. Okay, but the rest of them come to work and they want to do the best. All right. The NMC, the Nursing Council, have come and met the nursing staff. The GMC are going to come and provide an open session, and we're planning some other cultural work with the team. So, happy to take any questions.
Thank you. Thank you very much. Just going to go straight to members' questions. Diane?
Thank you, Chair. Gosh, I was expecting you to ask questions first. Thank you, Chair. I appreciate the opportunity, and thank you for coming. I think it is really, really important that we have an open dialogue. So I suppose maybe the first thing, in the interests of open and transparency, will you release the recommendations from the Peter McBride report also to the committee along with this document that you've released? That's the McBride report of 2023. I'm sorry, qualify that. The Minister said it wasn't a report, that it was a presentation.
That's correct.
So
yeah.
will you send us
I have
that
no problem in sending you that whatsoever.
That's excellent,
Diane.
thank you. I was
and
told...
that report never mentioned cardiac services at all, actually.
Well, it would be excellent just to have a look at that. And I think openness, transparency is really, really important in this issue. So that's the first one. I suppose I have been sort of, as you can see, reading the conclusions of the report and the recommendations. And I don't really want to focus on the behaviour because a lot has been said about that, and I trust that that is being dealt with and so on. But there's some really important conclusions in this report and important recommendations that will take us forward. And the issue of, and you mentioned it, Dr. Hagan, about surgeons in the unit still reporting each other. And there is, and I think you have to help us to understand this. So in conclusion 6, it is hard to escape the conclusion that some of the accusers in the unit have now, in some minds at least, become the accused. Conclusion 8, the suppression of resident doctors was routine, based on threats of GMC referral and MHPS investigations, and represents a risk to patient safety by inhibiting their ability to raise concerns, quite apart from the adverse effect on their training, effectiveness and personal experiences. Was the threats of referral to the GMC from management, from other surgeons. I'm presuming you as medical director know that. And I'm just trying to understand, and maybe just for everyone else's sake, what is, I know in general terms what it is, but in specific terms that would be helpful to know.
Okay, so my role as medical director is also a responsible officer. So I have a statutory role to ensure that doctors are appraised, revalidated, to ensure there's good clinical governance in place, but also to manage any concerns in terms of health conduct or performance around a doctor. Doctors have a unique framework called the Maintaining High Professional Standards Framework, which is how concerns around doctors are managed, and it's within their contract. But there's an ethos about how you can apply that, and I think that we have changed considerably the approach around MHPS in the past 5 years since I came into post. So, for example, when I came into post, there was we've got 1,400 permanent medical staff and another 600 or 700 trainees and what have you, with 1,400 permanent medical staff. So at that time when I came into post, there was over 100 files open on doctors. Today there's about 15. Okay, so we went from about between 7 to 8% of the medical workforce in some sort of process to less than 1%. There's nobody in a formal MHPS process at the minute. There are some doctors with restrictions which may be invariably due to health or something like that. And in terms of what you've read out from that, there certainly was nothing from the medical director's office threatening individuals within that team around MHPS or GMC referral. I've looked at the most recent data around GMC contact from the medical director's office, and it averages about 4 referrals per annum since 2020. And we have a very close working relationship with the GMC because I'm the link for the GMC in the organisation, and I work closely with the GMC Employment Liaison Advisor, and we will discuss any concerns, well, not all concerns, any concerns that I think meet threshold for discussion with the GMC ELA, and we'll determine whether that's something that can be managed locally or whether it's something that might need referral into the regulator for further discussion. So things that might come across my desk might relate, for instance, to a doctor convicted of drink driving, for instance. So that would be something that I would have to discuss with the regulator because there was police involvement.
Yeah, no, I accept that. So is, over the past 5 years, you said that has improved. Is the figure of 100 in this MHPS process correspondingly higher for the Belfast Trust than other trusts in Northern Ireland? And just in percentage terms, because I know you are a much bigger trust, obviously.
Very difficult to get accurate data on that, but the trade unions, BMA, HCSA, GMC and Practitioner Performance have all acknowledged that there's been a different approach in terms of how you manage issues around doctors. Because the most common issue that in my experience is around conduct, and usually interpersonal working within teams, and oftentimes that's best managed in a supportive, kind way, yes, rather than some formal process. But we have committed as an organisation, because there have been doctors raised concerns about how MHPS was applied, that we would have a review of the application of MHPS going back over the past number of years. Ciaran's commissioned that.
And when is that review going to start?
Restarted.
It's
restarted.
Right, okay. It's just that because I note in conclusion 13 it says, we are concerned that, they're talking about soft forms of bullying, refusing leave, etc., but they're also saying that we're concerned it might extend to MHPS professional reviews being used as a punishment. And if we have this, I presume, is going to be an external review into the process.
Industry experts.
And because I do think that is really important in reassuring clinicians that if they say that something is wrong and they speak up, that they are not punished in relation to that.
Can I say something on that, Diane? Because
yes, of course.
The referrals to MHPS are not necessarily referrals by the trust. Clinicians can refer one another to MHPS, and within the GMC, so that then puts people into processes. So that is not the trust taking action against those people in every instance. That may well be clinician A has a dispute with clinician B, and that's where it ends up.
Okay. That is very helpful, because I do think that if we can get the Peter McBride report, and we have this report, and I mean, I do think also we have to remember that this report is up to date. It is just reported on
May 15th,
and this report is still talking about poor behaviour, etc. within the trust, and I think that is really important. Can I ask a slightly different question? It's now 15 months since the handover of the maternity hospital. What progress has been made in that time in deciding, one, what is the course of action to try and get this hospital opened, and where are we now in relation to that? I thought you might have said something about that in your presentation.
Well, I suppose we were limiting the presentation to the issue around cardiac surgery, which is what we were asked to do, but we have no problem answering. Diane, a submission went from the Trust this week to the Minister, who has, I understand, is going to bring that then to Health Committee on where we are with the maternity hospital. So there have been a whole series of meetings with the appropriate people around next steps in terms of mediation, and you'll know there were a number of options, and the Trust Board has agreed the option from the responsible officer group, the water safety group, from the group of people who made that decision. That was brought to Trust Board last week and was ratified, and that has gone to the Minister now, so that our decision on the next steps, and there will be some caveats at that we are going ahead with one option, but obviously we'll keep this under review, given that there will still be concerns. We need to keep satisfying ourselves that the number of contamination events is managed.
Effectively, there were three options considered. The first was that you have localised mediation, which means in effect you go round to the taps which are currently testing positive for Pseudomonas and you remove them. Mm-hmm. The second was that we put in a discrete system for the most highly at risk neonatal patients, and they have a discrete water system. And the third was that the entire water system was pulled out. The recommendation between our own internal people and the independent reviewers who said it was that option one was not likely to solve the problem. Option three was, at their view, excessive. And at option two, where we had a discrete water system for the neonatal care unit, was the best option to take. However, we could be part the way down that road, and only when we open the system we find out that there are problems that at this stage we don't know about, and at that stage we might have to revert to option three, but we don't believe that's going to be the case, and the best advice that we can get from industry experts is that that won't be the case.
So just for clarity, if you adopt option two, I'm no expert in this, so I'm just thinking out loud, it won't. So if you adopt option two, that would ultimately mean that there is still some colonisation of Pseudomonas in water pipes in other parts of the hospital, but you would only replace the neonatal unit. If that is the option that you're going ahead with, and I appreciate you're going to keep it under review, I do accept that. If that is the option you're going ahead with, are you satisfied that that's a safe option?
The best advice that we have at this stage is that were we to go to any taps here in the building, we'd find Pseudomonas. So if we go for non-clinical areas and we apply a different standard to those than we apply to the neonatal areas where Pseudomonas is much more dangerous, the best advice we have at this stage is that option two is the safest way forward.
I mean, the full report has gone.
Costing for that?
Yes, and that is all in the full report, that the intention would be the Minister is going to share that, and that we are happy as a Trust to come back and discuss that with Health Committee.
Okay, and just because this has happened before, and I wouldn't like it to happen again, because sometimes we have a discussion with the Trust one day and find out another problem the next day. are we positive sure there's no more shocks coming down the line
In an
in relation
organisation,
to safety or any of these issues?
an organisation with 23,000 people with a turnover of £2 billion, it's impossible for me as chair to say I can guarantee that everyone is behaving properly. All we can say is that when issues have come out such as this, we have been open and upfront about it. We have been very clear what the standards of behaviour which we will accept are, and more importantly, those which we won't accept are. And that the key thing is that you deal rather than walk past the problems. I think we're being as transparent as it's possible for any organisation to be. But I guarantee that someone else somewhere isn't doing something. I just can't do that. But I don't believe anybody could either.
And just to add, I mean, we do have strong governance frameworks in place. We take, triangulate all our data from complaints, from our clinical outcomes, from our patient and our staff feedback, so that we are always on the lookout for something that may be bubbling. We're not aware of any.
Yeah, I suppose really, one of the issues is that every member of this committee has received this letter. And this letter is from concerned staff of the Belfast Health and Social Care Trust, which outlines a series of issues that are not just about the cardiac surgery unit, but they're about a series of scandals within the trust, Macmillan, neurology, cardiac surgery, as we've talked about here, but which outlines a series, but which also, and I'll just read you one sentence from it. This is a letter that was received at 7:30 last night to every single member of the committee. And I'll just read you the one sentence. It represents a wider culture of weak governance and lack of psychological safety for staff to speak out without fear of reprise. That's why I asked about the process around maintaining professional standards, because it is very unusual for us to get a letter like this and for staff to raise their concerns in this way. And that is, and
Well, hopefully,
I have no idea who it came from, and I'm not even trying, no one here knows. It's an anonymous letter, but it is signed concerned staff of the Belfast Health and Social Care Trust. And
we don't know whether that's from one member of staff, 10, 100,000. We only had sight of that letter this afternoon. Yes, there are issues on the capital projects, for example, which have been well rehearsed at Health Committee, of the number of issues that you've talked about, Muckamore neurology, which everyone is aware of. Over the 18 years in the Trust's history, we have had a number of issues. We are the only trust in Northern Ireland that does the full range of services. No other trust and you'll know from the Ray Jones report, if you're familiar with it, that he said we are probably equivalent to 6 to 8 other trusts in England. We have full range of acute and community services, mental health, learning disability, children's services, and things unfortunately do go wrong despite our best efforts. And over those 18 years we have had some very serious issues which we have identified.
I'm
and
not
addressed.
wanting to be confrontational, because I don't know when you saw the letter, but we only got it last night, and we can't unsee a letter like this. We have to actually act on this sort of a letter. And I mean, when you get a letter signed by staff of the trust, which actually talks about a stark disconnect between the leadership team and frontline healthcare workers, the absence of routine, meaningful engagement by senior leaders with clinical staff has created a void in trust and morale, and ends with, this poses serious risks to patient safety and service delivery.
Diane,
Well, I mean, I think it's really important that I challenge some of the things that are put in that. The directors in this organisation are extremely visible. Yesterday I did a town hall event with nearly 200 medical staff. I'm going to meet a group of general surgeons tomorrow. Myself and the director of Children's Hospital met the entire staff and children's a month or so ago in open forum. We've changed a lot of our governance processes in terms of how we have daily escalation to the chief executive if there's an issue, and weekly live governance where we look at all issues, complaints, SAIs, unexpected deaths, and anything from that is escalated weekly to the executive team and eventually trust board. We have safety walkabouts, and we are visible, and I found it really upsetting when I read this letter, because I don't think it reflects my experience of working in an organisation that I've worked in since 1998, and I'm very proud to work in, and I'm happy to talk to any member of staff about their concerns. And it's disappointing that the person that wrote this actually didn't put their name on it, because I'd love to have a chat with them and find out what their issues is. But I need to also reassure you that the department, as part of the independent neurology investigation recommendations, you may or may not remember, recommendation 14 was to look at governance within the Belfast Trust, and they were satisfied with governance in Belfast Trust, and they also commended us in some of the work that we'd done in terms of the learning from that, in terms of clinical record review and the information that we collect around doctors' practice. So that should hopefully give the committee some reassurance around that.
One more. Yeah, okay, thank you. Colin?
Thank you, Chair. Back again. Ciaran, we go back to Muckamore, we have the inpatient mental health building problems, the maternity hospital problems, the children's hospital delays, we've had the neurology, the hyponatremia, now the cardiac issues, and this letter from the staff. Are you fit to govern this trust, you and your colleagues on the board, and have you considered stepping down?
Well, firstly, that's a disappointing question, particularly when you put at the end an anonymous letter that no one can verify who it comes from, no one can verify what it says. Secondly, it's also deeply unserious. If you think sharpening a stick at both ends and impaling someone's head is the way to solve problems, then that is entirely contrary to being open. We are trying to bring issues to the fore and to discuss those issues. You have run across a series of events which date back 20 odd years. And I think to put them all together in 30 seconds like that totally misrepresents the trust, and it misrepresents the people who work there.
I mean, you've caused the public purse hundreds of millions of pounds because of your delays in some of your work. Like, for example, in the children's hospital, that's the trust, not you personally. Many of the things are leaving staff where they feel that they can't go to work. I've other staff approaching me about other issues within your trust. And it was very deeply concerning, if that's the language that you want to use, to hear yourself, Chris, talk about that there are problems, but things are generally grand, that you're trying to do the things that you can. It's like there's an excuse to let the staff behave the way that they're behaving. And that it is the line from yourselves, like if it was anywhere else, should be the behaviour is unacceptable and it stops. But it seems to be that you're giving time, space, opportunity for people. I haven't finished yet, Chris. You're giving people time and space to adjust their behaviour whenever the response should be the behaviour stops.
Well, Colin, you're betting someone's head off when they're trying to speak this behaviour, which should stop as well. So let's hold everyone to the same standards.
Sorry, Chair, I think
everybody's just going to have to take 10 deep breaths. I'm chairing the meeting, so we will allow a member to ask the questions. I would ask everybody to ask the question and respond in a courteous manner. This is an assembly committee and I want everybody to treat everybody in a respectful manner, so that includes both asking the question and answering the question. So there'll be no interruptions and everything will be done through me. So Colin, if you finish your ask a question, then we'll allow you an answer.
Thank you. And the point that is being made is it feels like in the middle of the explanations about the behaviour that there's a but. The behaviour is happening, but we're trying to address it. We're getting round to doing it. If it was in any other sphere, or if it was junior staff in many organisations, to be told if you don't shape up, you get out. But it seems to be here that we've got to try and accept that we've got to mollycoddle the behaviour. And I think if you had said at the beginning as well, Chris, that it was 2019 that this process began and it had been going on for a number of years before that, which means that we could be leading up to 10 years that these behaviours have been going on.
I'd like if you moderate your language a bit, because I don't talk to you like that, so please talk to me respectfully. But what I said started in 2019 was whenever I first became aware of it, okay? And I didn't become medical director until 2020. And I've outlined to you in great detail the steps that we took in terms of restricting surgeons, surgeons leaving the unit, recruiting new surgeons, and we've got another new surgeon coming soon, and the multiple disciplinary HR process that took place. But we also had a responsibility, which I think you need to understand, a responsibility to deliver a cardiac surgical service to the people of Northern Ireland. We had a commitment to deliver 950 cases per annum to ensure that the people in Northern Ireland got high quality cardiac surgery, and that team have delivered that. Now, where I think you're leading up to in this is, should we get rid of people? And the problem with that type of argument is that it makes it harder to deliver a safe cardiac surgery service. And we have an obligation to the people of Northern Ireland to deliver a safe cardiac surgical service. And what you can take, I hope, from this is that we've had 2 external reviews, 5 years apart, that have confirmed the service is safe, delivering high quality care. But importantly, we took measures like bringing Peter McBride in to try and work with the team to mediate between people and to try and improve working relationships. And we've restricted another surgeon due to their behaviour in terms of how they treated trainees. So we have taken action, but we've tried to maintain a service as well. And that's really important, because if we had dispensed with surgeons, then you would probably be criticising me for not having delivered a safe service because we weren't able to meet the SBA.
I accept the point that you're making, Chris. However, I don't like where it leads us to, because where it leads us to is that the staff can behave in whatever way they want to, because the overriding concern is the delivery of the safe service, not how they behave. And that may be creating the culture where they feel that their behaviour is permissible because they feel that they are too important to be moved on, that they're irreplaceable. And if that is an attitude and a culture that pertains within an organisation, I think it does leave us in a very, very worrying situation. I accept that it's a conundrum. I get that. But I think the public message going out there and saying that if you're in an important role, we can behave whatever way you want because we're going to have difficulty replacing you, then it provides an excuse for that behaviour. That's difficult to hear.
I'm not saying that, because we have tried very hard to manage very poor behaviour, and we have taken disciplinary action against individuals, as I have described, with discussions with regulators, etc. Okay, but these are confidential HR processes, and I can't discuss these in open forum like this.
Can I just go, we absolutely are not saying that certain members of staff are treated any differently and can get away with things. We are absolutely not saying that. If people meet the threshold for disciplinary, for example, they will be disciplined. The message, the focus coming out from this report is that staff feel unsafe to raise concern. That is where all of our efforts are going into, because they shouldn't. And once those concerns are raised, we will deal with them. What we found from the report where issues had been raised, we have either dealt with them, as Chris has articulated, or we are dealing with them, and there are ongoing processes. There are some of the things that we did not know about because, and this is where, it is important to us, because staff were afraid, the review tells us, to raise those. We have now committed to staff that we want them to feel supported. We have put in additional measures in the last couple of weeks. We've given occupational health time as our connections. We have worked really hard with trade union colleagues, and we will continue to make sure that staff raise them, and we have given a strong commitment that where they are raised, we will act on them regardless of who it is. There are different mechanisms for following up on conduct through MHPS, for example, for doctors, but it does not mean that we will not take action.
Well, I hope so. I think this letter, along with the 2 or 3 other instances I have, there is a repeated message throughout it. We don't feel like we can talk up. But I hope that we get that message out, that the Trust Board, that the senior management of the Trust bypass your bosses if you feel that your bosses are going to give you a hard time within your service, and go to the senior management team to report there. Not that, because some of the difficulty is that it can be a manager that you have a problem with, but the manager's best buddies with their manager. And then they feel that if they go above one level, so it's having a system in place where people can go to that bypasses the people that are causing the problems would be a good help.
And we absolutely agree with that. So we have whistleblowing process in the trust that does exactly that, bypasses, and that would be what is used in Northern Ireland. What the review has recommended, and we are absolutely taking on board, that there seems to be a better model in England in the freedom to speak up. That is not in Northern Ireland at this point, but we are going to follow that up. We are going to take the key elements of the success factors of there that include, for example, freedom to speak up, bodies or campaign, and we are going to start a campaign. So we absolutely do. I completely agree with you that the big learning for us is that how can we know what to fix if we don't know what it is we have to fix? And it is unfair, and it is indefensible that we have created, or we allow an environment to go on that staff do not feel they can do that. So absolutely 100% behind that, and so we're Trust Board. We accepted all the recommendations, and quite a few of those recommendations, like learning from the freedom to speak up. And we do believe that the additional support that the Minister's promised, there is someone with vast experience in this in England, and they will bring that learning, and we are absolutely happy to take it from them. And we will be happy to be challenged on it.
Thank you, Chair. Firstly, Colin, with regard to people speaking to their managers or being afraid to do so, to speak to people, we've introduced a system where that can be done anonymously through a QR code. So anyone can scan the QR code and they get straight through, and nobody knows who has said what. So that's a step in the right direction. With regard to the anonymous letter, we're a business that has a turnover of £2 billion. The anonymous letter may well be from one individual who has a personal gripe. You have no way of validating it, nor have we. There's enough data that we can actually talk about, that we can verify, that's been provided by independent sources, that we should concentrate on until we're able to establish whether or not that letter is legitimate or whether or not it's a personal grievance. We just don't know at this stage, so I don't think it's reasonable that an anonymous letter should set the tone for the discussion going forward.
Thank you, Chair.
I'm going to just kind of jump in here, because I was going to ask myself about the whistleblowing system, because, I mean, obviously we have read the report. There's lots of stuff in the report that we just don't have time to go into. But the thing that I particularly am concerned about is the first of all, the bullying of junior staff by more senior staff. I think that's appalling. But the concern by staff that they felt that, you know, if they were maybe scared to raise a complaint, and they felt that if they raised a complaint, that it was slow to investigate. So I'm interested to hear just exactly how your whistleblowing system works. I know you've started to detail it there, but maybe even the number of whistleblowing and the range of issues. So, you know, like is something, does it have to be a more serious offence for it to qualify as a whistleblowing in terms of maybe a more moderate complaint?
Their criteria have to be met. So we have a whistleblowing manager who reports then through the director of HR, and she will assess when anybody can make a complaint to her. So, for example, if there was fraud in it, it would be signposted on to the finance department and then to BSO counter fraud, or there may be a combination of issues, but they have to meet a criteria sort of in the public interest, or it's a safety issue, and they can be a wide range of, and a lot of the whistleblowing tend to be on conduct or performance, and they would go through the bullying harassment trail instead. But the freedom to speak up seems to go further from what I understand, and this is something we're only looking at, and Trust Board agreed last Thursday that we would certainly take some learning from that and try and replicate that as far as we can, and we'll tap into the Department of Health, but it would have more independence and reporting directly to Trust Board rather than going through a director, which does, I think, for staff, would give them extra assurance and more safety. So there seems to me, in the trusts in England, it seems to be working well. So we may be a pilot site for Northern Ireland, but certainly, if nothing else, we will take the positive aspects of that and try and replicate that in our trust.
And, I mean, I had asked the Minister when this story broke in the Assembly chamber about whether he would be prepared to engage with the trade unions. I mean, is there regular engagement between the trade unions and Trust leadership?
Yes, well, the trade unions, for example, were at all our town halls, but we would meet the trade union colleagues, the executive team, on a fortnightly basis, and then we have a wider meeting. I think it's every 2 months.
And I
every
meet
2 months.
the BNA through the local negotiating committee.
But on the ground, directors, senior managers and their team have really good partnership working with our trade union colleagues.
As an example, Chair, we're currently in the process of recruiting a substantive chief executive. And as part of that, myself and another non-executive director and the HR director met with people who would have a vested interest, and the trade unions were among those we met with, in order for them to tell us what kind of issues they feel that we face and what kind of person's required to solve those issues.
Okay, and I mean, I completely accept what you're saying about the anonymous nature of the letter. Unfortunately, since this story is broke, I mean, I've had phone calls from people who aren't anonymous, and I'm not saying they're making exactly the same complaints, but they have detailed some of these issues. And I know in the report, I mean, there's not only there's obviously details of the staff behaviour, but there's some criticism of trust governance. So, I mean, I can't remember if Diane asked and you confirmed. I mean, you are submitting action plans to the Minister. The last time I think we spoke, he said he hadn't got the action plans. Sorry, that was in the Assembly. He hadn't got. I mean, has he got the action plan? And is that something? Because I had asked him, will he make that public to us? And he said he would.
Yes, the action plan we discussed at Trust Board, our first draft of the action plan went to our Trust Board last Thursday, and then Tara, myself and Chris met with PHA and SPPG on Monday, and the Department of the Deputy Medic CMO, and we asked for their feedback, so they saw a draft version. We asked for some feedback, any other suggestions, and so we have been working on it all week, and it went either last night to the PHA and SPPG and the department.
Okay. And I mean, we'll see it when we see it, but if you can tell us at this stage, I mean, will any of the action plans cover governance within the trust and management?
Yes, we have themes. I don't know whether, Tara, you would want to pick this up, but we have themes within it. One, I mean, obviously, a culture piece. Then we have a bit on trust governance. We'll have a bit on freedom to speak up. That will come in our culture. And we have various work streams that feed into the action plan. We're absolutely happy to send you a copy. But, Tara, maybe you want to go into a bit more detail?
Yeah. No problem. Yes, as Maureen has said, the action plan, the 15 actions or the recommendations, we have a number of actions. Against all of those, we have 2 distinct work streams, and we are focusing on the cultural, governance, communication, our workforce through that, and we have inclusion of staff side as well with the action plan, and that has gone, as you said, up to Department of Health, and we'll continue to work on that. We have a weekly meeting, we have our terms of reference, and we will absolutely focus and work on that in collaboration with all.
Okay.
And maybe Chris might want to speak about the governance, but we constantly review our governance arrangements. One of the things in the review committee said we are a super sized trust. We have an assurance committee, which is a prerequisite of every board, that we have an audit committee and assurance committee, and they suggested that that's probably too big, so that we are covering the full range of items from clinical issues, cyber security, etc. And they've made some recommendations which we are already starting to look at, so that we maybe split that committee so that there is more time given and more focus given to clinical issues, and that will help. But it's a continuously evolving governance framework. We're tapping into, the department is doing some work in that, and we're trying to align with that, but we aren't going to wait. We're going to...
I'm sorry to interrupt, but I mean, you talked about the clinical committee, so one of the criticisms within this was the report saying, we noted with some dismay that the committee had decided not to table the minutes of feeder meetings in future, which included the clinical governance and social care steering groups work and our view important detail. So, I mean, is that something that's going to change going forward?
Before the report actually completed, we had a trust board There are a lot of papers, as you can imagine, go to Trust Board, and each committee does a report to Trust Board on any of the escalation items from their committee. And we had made the decision on Trust Board that we wouldn't necessarily need all the minutes behind that the escalation issues would be what's reported. We actually, at the next Trust Board, even before this reported, had decided that we actually would need all the minutes, because in case something was missed that wasn't. But we've tried to get our papers, for the purpose, because we've so much to cover. We try, for example, in the organisation governance, we try to put a sheet of escalation issues and then a sheet for each of the groups that feed into that, but without the minutes. But we had already decided, no, actually for completeness, we'll continue with the minutes.
And Chair, just to be fair, I believe that the criticisms in the report around the governance were not unfair or not unreasonable. I think they were reasonable criticisms, and I think we should take them on board.
Thank you, appreciate that. Last question from me. We're meeting the department next after yous on the level 5 and what it means. We hope to get some detail. Do you have any idea what it means?
We received a letter last week, and we have the first meeting with the, I suppose, the oversight group on the support and intervention on the level 5 next Friday. And I do understand that Tracey McCaig is joining later, so she'll be able to give you a bit more detail on that. But I mean, what it means for us, and we're, absolutely expected it. There will be more support given in an area that where support is very welcome, and we know with that also extra intervention, more accountability, until we can assure ourselves and others that we have this under control. And it is wider than cardiac surgery. We want to assure ourselves there is no evidence to suggest that this is widespread. We do know that in an organisation of this size and complexity, there are pockets of staff where teams, individuals, there are tensions between them, and that's, those concerns are raised and we take those through processes. But we do not believe that this is widespread, but that is what others will come in and help support us and reassure us, and they'll be reassured that it is not any more than you would expect in, I suppose, a similar organisation.
Thank you, Danny.
Thank you, Chair, and thank you for your answers so far. This has been going on for a long, long time. I was really shocked when I heard the initial reports of this. I couldn't believe it, but when I started talking to people who work within the trust and around other trusts, this was well known about for many years. It's astounding to me that this had not come up before. It's glaring from the report that people felt they couldn't speak up. There was no point in speaking up. People were being bullied. Junior staff were being bullied, medics and nurses. It really is a horrendous situation, but I was really, really shocked by the level of knowledge about this that people were contacting me about, and the length of time that they knew it was going on for. So I appreciate, I know Colin has said it's maybe been 10 years, but I think it's probably been longer than that. It has been very, very much embedded in the system. I know you're committed to getting grips of it now, but it is shocking that has been going on for so long and so many people knew about it. I just want to focus my questions on two areas. The impact in particular on your patients. I asked the health minister about this a couple of weeks ago, and he told me that off the top of his head, 6 patients had had their operations cancelled. He then changed that and said actually they had been postponed. So the cardiac surgery had been postponed. So 6 patients who were due for surgery, very, very sick patients, as at high levels of risk of serious actions happening to them, had their operations postponed. Do you know who they are? Have they been contacted?
It's actually 7 patients, and they've all had their surgery.
Okay.
And that was all done within a couple of weeks.
Okay.
Some of them within a couple of days.
Yeah. Mm-hmm. So they were all rescheduled promptly.
Are they aware that they were postponed for behavioural reasons?
There was one patient who was actually ready for theatre and prepped and ready to go, and the operation was cancelled at the last minute, which is a dreadful thing to happen to somebody.
all had surgery within a few days. Did any of them
All of them within a couple of weeks. But some,
weeks?
yes, that was Tara and I talked about this earlier. They were all completed within a couple of weeks.
Did any of them come to any harm in the interim?
Actually, one patient died in the post-operative period, but that was unrelated to a slight delay. There was a recognised post-operative complication, but that's in any post-operative complication like that, we will always do what's called an SAI review. So that's under review at the moment.
And the family would be aware.
Yeah.
So a patient who had his operation postponed because of the behaviours within the cardiac unit had his operation delayed
by a couple of days, but unfortunately died of an unrelated complication in the post-operative period.
Obviously, these are very, very serious issues with very, very sick patients.
Yeah.
Families have been contacting me terrified about what this might mean for relatives who are awaiting cardiac surgery. And, you know, the fear that you put into people who are already very, very unwell and very, very concerned about, you know, what might happen to them is very real.
If I could just say, I mean, that is, you know, the most serious thing to come out of this is our patients at a time like that, and Tara and the team have been putting additional support into patients as they come into our hospital and after recovery to make sure that they are reassured that there's a safe service and to see after the recovery that everything's okay. So that over the last couple of weeks we have put in additional efforts just to make sure, because we are very conscious of that, and I mean it is just adds to already heightened anxiety. Absolutely accept that.
Okay. The other impact I wanted to ask you about was the impact on the staff that had been bullied, particularly the junior staff. Have any of those staff left the units during these periods when they were undergoing bullying?
No, we've provided additional support to any staff that came forward. It predominantly was amongst junior trainees and not senior trainees. And through listening exercises conducted by ourselves and by the training agency, we identified an individual who was responsible for that, and they have had their access. They don't work with trainees, certainly junior trainees anymore.
That's shocking in itself that you can't have somebody having access to a junior trainee in case they bully them.
If you remember when I talked earlier on, we had a similar issue with another surgeon back in 2020 who was also restricted from access to trainees as well. It's complete. I mean, I'm a surgeon as well. It's completely unacceptable.
It's shocking to hear it described.
Well, particularly as your junior staff are the future consultants and SAS grades that are going to come and work in that unit, and it sets an awful tone in a unit if trainees feel bullied, feel frightened to speak up. And I must say, having spent 20 odd years in surgical practice, it's not something that I've been familiar with in any unit I've ever worked in, other than a brief time when I worked in Dublin, and the impact of that on a trainee is quite profound. I was offered a job in Dublin and I thought, I don't want to work in this unit because this is how they treat trainees. So it is utterly unacceptable that trainees and nurses will be bullied. I cannot, and you know, I understand that it's high risk surgery, but people have to manage their emotions. You know, I've spent half a lifetime at operating theatres, and I've seen excellent behaviours, particularly when things don't go well, because that's whenever you actually need your team round you. It's not to make them feel frightened. So it is completely unacceptable, and I will never defend people treating people like that. It's just awful. But the encouragement I hope that we can give you is that we've recruited 2 young surgeons who are really excellent people. We've got another excellent young surgeon hopefully starting in the summertime, and hopefully with time the culture in the unit will change. But as I said to you when I did my short presentation, we still have surgeons, more senior surgeons in the unit, raising concerns against each other despite everything that we've talked about.
And that's kind of where I was going to go. I wanted to talk just about the damage to potential careers, and you've highlighted an example yourself where you didn't take up a job because you felt the behaviour in the unit wasn't right for you. Who have we missed? You know, we've missed people. Careers have been damaged here, and I would imagine people have felt scared to come into work and stressed, and you know, it's horrendous what it must have done to those people. And just what you were saying about the 2 new surgeons, that's great.
Yes.
But as you've also said, I think, was it yourself, Ciaran, said it takes 5 years to change culture?
So we linked in with another unit. I'm not going to name it, but this is a problem that seems to be not infrequent in cardiac surgical units. There's several units in GB that have had similar issues to ourselves, but they have seen poor patient outcomes associated with that. We haven't seen that, but what we do know is the impact of incivility within teams eventually does affect patient outcomes. This team, despite all the issues, have managed to maintain excellent outcomes as validated by NICOR, so they're the group that oversees it. And we look at individual surgeons' performance plots as well, and they're excellent. And the patient experience in the unit is fantastic as well. So I mean, it's consistently over 98%. We take regular feedback from patients of what they think. So despite all, I'm not trying to minimise the issues, but despite all that, the outcomes and the patient experience is excellent. And we actually have had patients coming forward saying, "Can we please say what it's been like?" With really good experience, because there's about 250 people working in this unit. Okay, and what we're talking about is the behaviour of a very small number of people that finds us sitting in front of you today, when actually there's over 240 people want to come to work and do a really good job, and we need to support them and recognise that.
But it's probably a good opportunity to recognise the staff who do come in every day, despite the behaviours that we've now become aware of. They have come in every day and worked together, and there are teams within the wider unit who work really well together. You know, ICU and the cardiac surgery have really good relationships, but some of those, I mean, a lot of the examples in theatres, those nurses turned up, looked after each other. It is not acceptable. It's indefensible that they should have had to, and we won't tolerate that happen.
I can only hope that it improves for them now. And just to finish off, Chair, the Minister has now confirmed the Trust is in the highest level in the support and intervention framework, which we're about to hear about, which we finally got from the Minister on, I think, Wednesday evening. How will we know that your actions, the actions that you've outlined here today, and there are quite a few of them, are delivering positive change? How will we see the difference?
Well, I think one of the first things to say about that is one of the reasons why we gave everyone a copy of the report was so that those who work within the unit can see what the recommendations were, will understand that we have accepted all of them, and will be able to judge us on whether or not we deliver upon those things. In the past, when there have been reports and recommendations, they were not shared as widely, and that was one of the things which has come out in the report, as you'll see. So we decided we'll err on the side of transparency, so that we are telling people what we'll do, and we've asked them to hold us to account for it. I did that at all 3 of the town hall meetings which we had, and we've undertaken to go back to people to let them give us an opportunity to tell us whether we're doing it or not.
I will expect this committee will take a very, very close interest in those recommendations and how far they're being progressed. So I imagine we will be talking about this.
You would be very welcome to come to some of those sessions and to hear from the people themselves, because we have no interest in hiding anything.
Yeah, and I would be very happy to do that, and I'm sure other members would as well. Thank you for the invitation. Thank you, Chair.
Thanks. Arlia?
Thank you, and thanks for your time at committee today. Like all of this, these discussions are very negative, and I'm conscious, as we've all said, the public will be watching on, and particularly patients and families who are due to maybe go in to the hospital, either whether it's cardiac or for one of the other services. And I do think it's important that out of all of this, it's the trust of the patients who need the care and the treatment, that you're maintaining that. And just to say, one of my extremely close family members has recently had surgery, not in the cardiac, but in a different service. So that's where my mind is at in terms of all of the life-saving work, literally, that's being done every single day, and that is just to be commended. The most important thing overall is the service is safe, and you've made that clear, that throughout all of the bullying and bad behaviours that patients haven't been impacted. And that is really, really important that that message is out there, because that's certainly what I would want to be hearing if I was due to go in for cardiac surgery or for indeed any surgery in the Belfast Trust. So just around, Chris, you had mentioned all the steps that have been taken over years to address the concerns and the issues that you were facing. And you have mentioned, Maureen, that the evidence was suggesting that it was all sort of in hand and it was being dealt with. But then obviously you weren't aware of just how widespread it was. So my first question is around, given that you are aware of that now, obviously with hindsight and with the reports that have been done, as a leadership, can you confidently say, and I know, Ciaran, you were saying it's hard when you're talking about thousands of staff, but can you confidently say that in terms of widespread bad behaviour like this, that it's not currently taking place elsewhere within your trust service? I know, Maureen, you were saying that there's people that's going to hopefully come in to help you have that overview and, you know, really get into the detail of that. But as you sit here today, have you done any sort of auditing, any check-ins right across the service, just to be able to stand over to say, look, at this point, you know, we can say, or we would be hopeful that serious issues like this aren't currently widespread in another part of our system?
I suppose for that, I mean, obviously there's been a focus in cardiac surgery on the staff there on a daily basis at their daily huddles, but as well as that, we had a nurse event in the last couple of weeks about speaking up. We had an all-user comms went out on Monday of this week about to remind staff the various ways in which they can speak up. And then all of our directors through Trust Board and Executive Team have been going out to all their teams. Yeah. So this, whilst some of this work will be very specific to cardiac surgery, some of the recommendations, many of them are cross-cutting, and the cultural piece will certainly, we have already set up after the Peter McBride work, we set up a number of strands. We've chatted with the chief, but the big outcome of that was our Open Learning and Just Culture Steering Group, which feeds into Trust Board and is led by the Director of Social Work, who obviously is steeped in that whole world, and HR, and that work has been going on, and now we take feedback from that, get a bit of a temperature check on the organisation. Mm-hmm. But there is much more to do, we know that, and we will use all the help and the things we've already started here to try and to capture how staff are feeling. And we've just closed our staff survey, this year's staff survey, so we'll get again a sense from staff, are things improving? You will know at COVID, and this is not unique to Belfast Trust nor Northern Ireland, morale amongst staff was at its very lowest. Then after that, a number of years of industrial action, etc. So our staff survey is trying to take a sense check at regular basis, and those outcomes have been improving. So we will continue to do that. That's the work that Chris talked about from. That was out of the Peter McBride one.
And Chair, if I may, just on that, it's a good point, Darla. I'm a non-executive within the trust, and the problem when you're a non-executive in any organisation is you don't know what you don't know. Mm-hmm. But when you find out, you have a responsibility to do something about it. It's been very clear what has happened here, and we have a responsibility to fix it, and we will live up to that responsibility, is all that I can say.
Could I just add to I think it is really important to reassure the public of not just cardiac surgery, and you said yourself, anybody going in for surgery, people, CHSCT, who are the primary benchmarking company in England who look at performance across trusts, did a piece of work a couple of years ago in the trust, and in all but a few of our specialties, they reported that our performance was as good, if not better, than the peer. And by peer, I mean other teaching hospitals, other centres of excellence, were the few that we weren't above peer were usually a capacity issue, and we have been working with others to do that. But we have cardiology, for example, is in the top percentile of UK. We have a European standard, head of European standard renal transplant surgery. So I think it is important, and thank you for bringing that to attention, to reassure people that we have exemplary services right across, and it's not limited to our acute hospitals, but it is important to remind people of that.
Yeah, because as I say, and I know I was using the example of my close family member, but regardless of what type of surgery someone's about to go in for, if you're hearing this, it's going to spook you. You know, if you know that you're going onto an operating table, regardless of the reason or what service is carrying it out, this news and this report and all of this talk is obviously going to, I think, spook you. And sorry, Chris.
But we have excellent clinical outcomes for cardiac surgery, despite their problems, because cardiac surgery is heavily monitored, and they submit data through what's called NICOR, and we monitor individual surgeons' performance through what are called VLAD plots, so we can see what their outcomes are, and if we see a plot starting to drift a bit, we will provide support to that individual surgeon to maintain their performance. And as I said to you earlier on, 2 of our surgeons have been recognised as being in the top 5% of cardiac surgeons in the whole of the UK.
Yeah.
So, you know, despite the issues in this team, they continue to deliver high quality, safe care. But it's really important also that we have at least 50 plus clinical services in our organisation, and people come to work to do their absolute best. It's a massive organisation with 23,000 people. We will get issues in some services. You know, people are people, and people will sometimes not get along with each other, and we need to be honest about that. But it's how we deal with it and how we're open about it and how we bring these issues to the fore. And we've described how we've shared this report with all the staff, warts and all, so that they understand that because they've come forward, we will take action.
And thank you, Chris. Just finally, the second question, my last question, it is just around that issue then of the staff feeling fearful, unsafe, afraid of reporting then whatever the problem is, or whatever the bad behaviour, the bullying, or whatever the issue is. And as a leadership, what is your assessment as to why staff would be or could be feeling that way? Do you know, is it coming down to individuals? Is it the reporting process if something does go wrong? Is it a lack of trust? You know, in the sense of, if I do report something, will it be followed up on, or will it come back on me? Or, you know, it's just how do you get to the bottom of that? Because it's not good for anyone to be feeling that way. And going forward, if you're going to try and implement the recommendations of this report for the cardiac service, I think the real thing that you need to get on top of is that feeling of staff feeling fearful and afraid to speak up, because you're always going to come up, there's always going to be another issue, another scandal, another service that's potentially going through this process if staff are feeling that way. So just your assessment of that issue in itself, just around staff feeling afraid.
And that is what our campaign around freedom, feeling safe to speak up, using the freedom to speak up, using what we're already doing, it will be all about. What has led these staff to be fearful, I can't say. The review didn't say. I suspect for some people it will be, this could be somebody interviewing me for a future job. It could be, I'm afraid of retribution. I'm afraid of a complaint being made against me, or I just want to stay under the radar. None of those things are going to help this unit move on. So we need people to feel, and if it is, whistleblowing keeps it completely anonymous. This report was anonymised, but if that is not enough, then we need to do what it takes to make it enough that people feel safe. And there may be a bit, I suspect, and I think it came through, you know, well, I complained before, nothing happened, because processes do take a long time, and sometimes, for example, it's whistleblowing, it does not have a 360-degree look back to the person making the claim, because that's not the way the process works. But that's all the things we need to tease out. And the nurses particularly, you want to say at the town hall, if you go ahead, Ciaran.
Thank you. At the town hall, the nurses in particular, from the report, they have spoken up, they have felt safe to speak up. But since that, just referencing the NMC event, that wasn't just nurses from the cardiac surgery unit, that actually reflected many of the nurses from other surgical disciplines across the trust. And we have spoken to the nurses, and we've actually evaluated how that session went, and they are feeling very positive to speak up. again, as Ciaran had said, we do have a very confidential, with a QR code. If staff do want to speak up in a confidential manner, they can do that as well. But we are sense making and checking as we go through these actions as well.
Thank you so much.
Okay, and I'm not discriminating against the two Allens because they're last, but we have to be fair to our next presentation here there. So if we can get the answers succinct moving forward, Alan.
I have a very brief, Chair. Just I want to refer to this anonymous letter that we got, and as my colleague Mrs. Dodge has said, when you get something like that, you can't unread it, and you ignore it at your peril. But by the same token, I'm very, very uncomfortable getting anonymous letters when there are other means of people, coming and talking to me anonymously or whatever, and in confidence. So I'm uncomfortable with it, and I'm conscious of what Ciaran said. It could be just one person sitting in their bedroom with a catalogue of grievances and typing out that letter and signing it, a concerned staff, plural. But you did indicate, and I'm pleased to hear it, that you have regular dialogue with the unions every couple of weeks, and maybe a more formal setting once a month or every couple of months. I would have thought that I'm sure some of these concerned staff are members of a union. Do you identify anything in that letter that the unions have been bringing to your attention in these meetings? Because I would have thought if whoever wrote this letter was genuine and had real concerns, I would have thought the union would be the vehicle to articulate it to yourselves. So do you identify anything in it that the union, have they been bringing stuff to you?
I suppose the union, for example, at our fortnightly meetings, we would discuss all of the issues that would be pertinent to the running of the trust. So, for example, after the health committee meetings or even before them, so we have discussed, for example, capital projects, what does that mean for staff, etc. So we do raise those. So they were in the letter, but no, the other things, no. I mean, but trade unions we will always have conversations at every meeting about staff's ability to speak up, or any concerns that staff have. If there were groups that the unions, they would draw that to our attention, but they wouldn't have to wait to those formal meetings. Our HR colleagues and our service directors and their teams have a really good partnership, working relationships with the trade unions. And I'm saying that, obviously there's always room for improvement. I'm sure trade union colleagues would like more from us, and around these issues we will be happy to do that.
I'm sure that a lot of what's in the letter has really been picked up by the report in the interviews that you did. So there's really, I didn't see an awful lot of new stuff in it that I wasn't already aware of by virtue of having got a copy of the report.
Thank you, Chair. I think the reality is that when you don't know who has written something, it's very difficult. It felt, I only got it when I was eating my lunch, it felt as though it was based on personal gripes. It's likely that the individual is a constituent of some of you, and if they would come forward and speak to some of you on a confidential basis, you could come back and bring the issues to us. We have no interest in hiding from any of the issues, but it felt like a personal gripe in parts of that to me.
That said, the line in it that said, not signing it whether it's an individual or not. I mean, the same message is, we don't feel safe to say whether that's true or not. We know that is an issue for us, and that is what we are going to focus on. So out of that letter, the big thing would be, for me, well, why did you feel the need to be anonymous? Why couldn't you feel that you could go through all of those processes that you're talking about, or a new process, a better process? So that's what we would be focusing on, that letter.
Chris,
I think, just to go back to something that Diane brought up about the management of concerns around doctors, and the change in approach around that has been recognised by the two main doctors' trade unions plus GMC and practitioner performance, that there's a different ethos in how these things are applied. I think that things like this take time, though, to be recognised across an organisation as large as ours, and you will. Some of the things that came out in the report I felt were historical issues that we probably dealt with before. But I mean, the letter that you refer to, it's very upsetting. It's a shame that we can't have a conversation with the person, or that they didn't feel that they could put their name and talk to somebody about it.
Thanks, Chair.
Alan Robinson.
Thanks, Chair. Look, folks, at the last session we had with the Minister, I had used the term that it felt a bit like a Wild West bar, some of the behaviour that was happening here, and that was based upon some of the information that we were getting at that time about the risk of violence in the unit, and that the environment was not safe, and an allegation of implements being thrown. But I suppose following that, and since we got a full copy of the report, it feels a bit more to me now that it's the stuff of the playground. We as a committee, and you people as professional people, we have more important things to be getting on with rather than the behaviour and the patient behaviour of people within that cardiac unit. I'm sorry for being so blunt about it, but I think it's shocking that people who are grown adults can't behave themselves, and that there has to be a costly report carried out, ministers involved, there are motions within the chamber. Here we are today having a session on the back of people who simply can't behave. I think that's just disgraceful. Can I just ask a question then on the back of that? Do you believe, give us a wee bit of a nugget here, do you believe going forward, are you confident that you believe that there will be harmony in that cardiac surgery unit?
What I can tell you is we
Because the
have
report
told
doesn't suggest
staff,
that.
and we've told the board, we will do everything we can to make sure that we have a safe environment for people to work in and training, and we will do our utmost. And where behaviours and people will, and they have already felt freer to raise even small complaints, and that has happened about behaviours, we will act on them quickly. Whether doctors' tensions between individuals changes, frankly, that's up to them as well. People have to take responsibility for their own actions, and where they are not, then we have to address that. Can I tell you that they will like each other and work well with each other? No, I can't guarantee that. What we will ensure is that their behaviours aren't impacting on other people in the unit and in the safety that they feel.
And I've had some informal feedback from trainees that saying they've noticed a change. We've had a letter from a senior trainee saying that they enjoy their time working in the unit. But I think, and we've taken immediate action in respect of an individual who's identified as bullying trainees, because it's completely unacceptable. And we took action about that in 2020 with another individual as well. I think it's really encouraging that we've got 2 new consultants appointed in the past few years, and we've got a 3rd consultant coming in the summer, and we have other people who I know that want to come and work in the unit. So I think these are really positive things where we can reset the culture in that team. But I need to try and give you some reassurance that this does not reflect the culture in other teams in the organisation, and other teams in the organisation are very upset that they feel that they're being judged by the behaviour of a very small number of individuals, because we have a giant organisation that we're all really proud to work for and to lead, and that this does reflect really poorly the actions of a very small number of people. And I'm glad what you said.
Just another point I noted in the report, there was commentary on having to wait 8 weeks for some of the documents to be uploaded. Was there any reluctance on your part, or what was the delay?
Issue with the data sharing. Sorry, there's an issue with the data sharing agreement, and the PHA commissioned it. It wasn't ourselves. So there was an issue around the data sharing agreement. It wasn't that we were trying to hide anything.
And the DCO were confident they got everything that they required, everything that they asked of, they got.
Yeah, yes, and I suppose some of the feedback what we've had from our staff is that actually we could have given them more evidence on that, so we probably could have got more, but there was a time constraint. So for example, there was a lot of there was recommendation that we would go beyond the NICOR for some more personal data, and some of our staff are saying actually we could have given them more of that. So that's on us, and probably the time scales and the data sharing, and then there was time for redaction. So, but there was nothing that the review team felt they needed to give them more assurance on the safety. There were a couple of things I think we could have given them to make that even stronger. But
and they gave us some recommendations about our assurance framework, which we were actually doing some work around as well, because we have a big thing called Assurance Committee that covers a lot of governance, and we're going to try and separate that so that we can focus more on clinical governance within the organisation and have a separate for social care. And that was one of the recommendations also from the neurology inquiry. So I actually met somebody from the department today who's been working on the recommendations for that.
I suppose the key assurance for you is that absolutely there was no intention to hold anything back, and hopefully the fact that we shared an unredacted report is testament to the, demonstrates our openness and transparency.
Chair, look, there's a couple of questions, but I'm conscious that we've run well over.
I'm going to allow your colleague come on with one very quick question and answer.
Thank you, Chair. First of all, can I say, if by raising these issues they are now being addressed and talked about, that's a good thing. Every day I am humbled and grateful for the work of our NHS staff who do so much for us when we are at our sickest and most vulnerable. And I think that's important. Can I just ask again for complete clarity? If the Minister was sitting in front of me now and I asked him a question about issues within the Belfast Trust around the safety of patients, would there be something that he would want to tell me?
Certainly not that I'm aware of, no.
That's fine. Thank you. And thank you for coming. I do appreciate that. These are not easy issues.
There's not something next week that we're not aware of.
Well, that's what happens.
But we're I think we've demonstrated our commitment to being open and transparent in this. And I hope you think that we've
Thank you very much. Thank you all for coming. Appreciate that.
Listening to
Thank you.
So, members, we are going to knock some items off the agenda. No? Switching them around, so we're going straight to the. Where are we going straight to?
I can just ask for
back
to, is it possible for the committee to get the library to do a report for the committee to do a paper on the size of the Belfast Trust, just how big it is in comparison to other trusts here, and some sort of comparative data, because on a number of occasions they talked about how big their organisation is, and in organisations that size there's bound to be things that they don't know about and they're not aware of. It mightn't do us harm to get a sense of how big it is and what is there, because if that is going to become an issue, maybe it's one about more resources as opposed to anything else, but we just can't keep hiding behind we're too big an organisation. There's bound to be things happen, but if it's the size of 6 or 7 trusts in England, then maybe there is something that we need to look at there.
There is a point in if you look at bullet point 63 in the report, it actually says something about the sheer breadth of the trust's activity. So, it's a good suggestion.
A simple paper that kind of details why it's the size it is. And
I think that is an important suggestion, but particularly, this is not just a hospital for Belfast.
Yep.
This is a hospital for Northern Ireland. Yeah. It carries all of our really high-risk regional specialties, and therein is a decision that was taken, I suppose, many years ago to put them in the Belfast Trust, and therefore it's important to know if it's now manageable.
And it's also an important point given potential future reconfiguration of additional services. So
just a quick
thank you, that's a good suggestion, and we'll take that forward. So just we're moving then to item 12, which is the oral briefing from the department on the written ministerial statement on the review of the RVH cardiac unit. So can I refer members to the ministerial statement, page 30, and we will welcome our guests now. Tracey McCaig, Lisa McWilliams. I don't want to come in.
Would you?
No. Let me tell you, I'm trying to get out. So thank you very much. Just welcome Tracey McCaig, Chief Operating Officer, SPPG, and Lisa McWilliams, Director of Strategic Performance within SPPT. So you're very welcome.
Thank you, Chair.
We're going to hand over to yourselves just for some introductory remarks, and then we'll ask you questions.
Thank you very much, Chair. I appreciate that. So, good afternoon, and I know you've had a busy day, but thank you for the invitation to...
I should say apologise for the length of time.
That's fine, that's fine. We know how these things work. And just thank you for the invitation to update the committee on the Department's response and plans to ensure that the Belfast Trust implement with pace, with urgency, their action plan to address the recommendations set out in the independent review of cardiac surgery provided by the expert panel. At the outset, I wish to convey to the staff and to those who have or will be using this critical regional service that we have heard you and we will continue to listen. We are appalled that staff have had such an unpleasant experience. I do not recognise this as the health and social care service that I've dedicated my time to. The findings are absolutely unacceptable, and the Minister and the Department have clearly articulated this previously. I would acknowledge that in recent years there have been reported issues within the cardiac surgery service, and it's been relating to good relations and culture. In response, the Trust had invited an external review by the Royal College of Surgeons in 2019, which reported during 2020. In addition, in 2021, the service was placed in the General Medical Council's enhanced monitoring for the training of resident doctors. The Royal College of Surgeons review confirmed that the service was safe, but made recommendations around operational restructuring, including separation of the cardiac and the thoracic surgery consultant teams, as well as changes to management, clinical cultures and relationships. The Trust had undertaken significant work to implement the Royal College of Surgeons' recommendations, and progress on this resulted in the General Medical Council removing the unit from its enhanced monitoring process. However, disappointingly, in December 23, the Public Health Agency received allegations about the service. These related to patient safety and culture within the team. The allegations were shared with the Trust Chief Executive, and immediate assurances in relation to patient safety were sought. They were received back from the Trust their position on that. But as part of our role within the Department, within the Public Health Agency, our own teams have been continuously reviewing the information, and that's part of our normal oversight arrangements. Also, the Trust clinical governance arrangements within the Trust were reviewed. So there was no evidence of immediate patient concerns from that review. But we do understand that patient confidence has been shaken. And I would reiterate the Minister's statements, the independent review report findings, Public Health Agency and my own performance team's views that the clinical outcome reports indicate that patient outcomes are largely equivalent to other UK services, and the independent review report further highlights that the clinical competence of the individual anaesthetists, the surgeons, and they are a strength to the unit. The outcomes are supported by the National Institute of Cardiovascular Outcomes Research, which is a national audit of similar services, but we must not, however, rely on this alone. The Patient Client Council are working with the Trust to ensure that the patient voice is heard within the improvements, and they will work to ensure that individuals get the information, advice and support as they may need if they are requiring services from the unit. There is much to do, and the Minister is clear in his expectations. This matter has been escalated to the highest level within our performance accountability framework, that is level 5. In assessing an increase to level 5, there is judgment on whether the current Trust team can, with support, make the necessary improvements or whether alternative actions are required. Under the Minister's leadership, previously advised, Peter McBride will be one of 2 experts who will support the Trust in implementation. Both of the individuals come with significant experience, Peter with knowledge of the Trust and elements of this service, and the other person whose name I can't say just at this moment being finalised is someone with very senior NHS clinical and medical governance experience. With their advice and insight, this will support Belfast Trust to consider the implications of culture, of being open, as well as the specific recommendations of cardiac surgery. Our independent regulator, the RQIA, will also be vital in providing overall assurance in due course. Given the level 5 status, our normal accountability arrangements have been enhanced. We have now included the Chief Nursing Officer, the Chief Medical Officer or their deputies. The 2 independents that I've mentioned will also have an assurance function, and we are still in process to try and have one of the report authors sit with us in that accountability framework to give overall assurance. That is yet to be confirmed. This will provide a regular and informed assessment of progress with the ability to consider further actions as set out within the framework. And the framework can go up and can go down, and that will be a continuous fluid judgment that we will take. The Trust draft action plan has been received yesterday evening, and our teams are already working through that from the Department and the Public Health Agency. We are considering that against the review recommendations and the wider requirements as requested by the Minister. So in short, we are looking to see to have improvements around clinical governance, the culture and openness, not just within the cardiac unit, but in a widespread scale within the Trust. And absolutely critical for us to restore public confidence in this regional service. This is our only cardiac surgery service in Northern Ireland. It is absolutely vital to us that the public confidence is raised. So thank you for the moment to say that.
Okay, thank you. That was very useful. You ended just where I was going to begin in terms of the impact across the Trust. It's not just because I mean that I'm a wee bit still unclear, and I presume the public are a bit unclear as well, because in the Minister's statement he said raising level 5 for the Belfast Trust, but a lot of the detail in the statement was specific to the Cardiac Trust. A lot of what you were saying was specific to the Cardiac Trust right until the last paragraph, as it were. So can we just get clarity? So these measures, the 2 independent people, the Chief Nursing Officer, Chief Medical Officer, whatever other, whether it's somebody from the report authors, they will be looking at the governance management systems within the whole Trust beyond the cardiac unit.
That would be our expectation. So with the 2 independents who will be working with the Trust, and obviously with the PCC, where there is a focus on cardiac because we have recommendations which we need to ensure implemented, we do not want to presume at this point that there isn't a job of work to do wider. I think the concern for the Minister and for ourselves was that in my statement I've made clear this is something that has been brought up before, the culture within the team and the relationships within that team. So either what we implemented before or the Trust implemented before didn't hold or didn't work, or this is a situational time-based thing where something different has happened. We have to make sure that that is not something which is wider spread, and that is part of what we will do as part of this process. That is the reason for raising the level 5 to a wider, and it is about general public confidence, because if you rock confidence in one service, you could rock confidence in other services in the Trust. So we will want to work with that within the actions, but absolutely clinical governance is not confined to cardiac surgery alone. So we want to ensure that the best system of oversight is there within the Trust, and the second person, who unfortunately I can't give you the name of today, is someone with that significant experience who will be able to provide that mirror to the Trust. And then the staff piece. We have all heard different pieces of information even since this came out. It's important that we provide confidence to the staff across the Trust. It's important we provide the confidence outwardly from the work that we're doing. So it's both sides, cardiac but broad as well.
And the Minister, in response to, might have been me, should know if it was me, but he said he was going to make the action plans public, wasn't he?
Yes.
So you've got them yesterday. Can you ask?
It's a draft yesterday, so it was last night. Lisa and I were both away with colleagues in NHS Wales and NHS England, so I haven't had time to get into it in detail. Colleagues are already looking at it today.
So you've got a draft plan. Who decides whether it's finalised?
So probably helpful, so the accountability team that are put, so there's 2 levels. One within the Trust, they will have their oversight team with the 2 independents working with them on the practical application of what they need to do. We will have, sitting above that, with departmental level, our normal support and intervention would be myself, I would chair. Lisa, from a performance perspective, will be there with the chair and the chief executive of the Trust and their director of operation planning. We are enhancing that and lifting it up to have the CNO, CMO and others in that. That broad church of people will have to look to see whether we think that it is addressing all that we want it to address. That's why we would also like the report author who has an insight on the cardiac element, but it will still be there. And Peter McBride and the other person will provide assurances up and in. So we're trying to make sure that it is comprehensive, that we've got the right people around the table to augment the process, that it is not narrow, but it is broad. That's what we will look at to see that it fits. I think there'll be others, there may be other elements that we need to look at during the time. I don't want to preempt what that might be, but certainly at this stage that's our starting position, and we want to make sure that the action plan is comprehensive. And to be clear, I don't want a tick box. I don't want us to say, tick, I've now got public confidence because I've done a range of activity. This has to be for a slightly longer term because we've tried this before. This has to be something that we will look at over a period of time and ensure that these things are embedded and work.
Yeah, and I totally accept that, and I think that's what everybody's outcome would want to be. But there is that kind of public confidence issue that we're currently in. So, I mean, I presume this team looking at this will be providing the Minister with regular updates?
Yes. I have set out that in the first instance these will be fortnightly. If you do weekly, there'll not be enough time to get lots of activity done, and there will be work on the ground that's working at pace, and operational teams will be working, but the oversight will be fortnightly in the first instance. The first date is in the diary, I think it's 20th if I can remember my dates. That will be the first meeting, but in between now and then that will be the operational conversations will be going on the action plan. So we would hope at that date that we agree the action plan that's reasonable and sensible. I'm hopeful by that stage that our experts will be available to us at the same time, and then that'll be about moving it forward. And Minister has committed to provide regular transparent updates on progress and actions, so we will take that as part of what we will do.
And will this committee receive regular updates?
I would expect that's the Minister's intention, certainly what we've discussed, that it would be absolutely open and transparent as we move forward. That has to be part of what we do.
So, thank you. Colin?
Thank you. You caught me unawares of thinking of a question. I hadn't written it down. Yeah, I suppose quite often there's references in the report, and thank you for it, in terms of culture. And I'm just wondering how far that reaches, because to me a culture is set from the top and it permeates right the way down. I know there can be a turn of phrase, and I accept that before I'm sure there's undoubtedly a complaint about this, but we had a letter that was unanimously sent in to us, and the references from our panel included the term that it might just be a personal gripe. If the culture is that people complaining is a personal gripe, that may set the tone that if people feel that they're talking up, that things are... So I'm not saying that that is a culture, but will we look from the top to the bottom in the trust, or is it just this individual team? And I know we mentioned earlier there about going round to other parts of the trust, but will this include an examination of the trust board and how they set the culture, how the senior management set the culture, and how that permeates down into this unit and beyond?
Thank you for the question, because I think it's really important, and it's part of the reason why this is at level 5, okay? Because this is then escalating up to wider corporate conversation. So culture absolutely set from the top, and you know, we all in our place of employment try to model what's good, but it's also for each individual, and I think if we're going to look at it, we have to look at it from both spaces. Peter McBride, who is working with, will be looking at in its broadest sense, as well as looking to see, have we got the right conditions for speaking up? When you do speak up, how is it received? How is that received within the trust? So I think both things can happen at the same time. So I think it's going to be hard because we've got a very specific problem that we need to deal with a set of recommendations, and then we have to do the way, because if we do one, then we'll miss the next opportunity. So I think we want this opportunity to be a once and for all, and to really set it into the next phase. I think the other thing to bear in mind is that we are currently recruiting for a chief executive, a permanent substantive chief executive of the trust, and that is it's imminent. I don't necessarily want to say the dates, that would be inappropriate, but it's imminent, and if that is successful, that provides another opportunity for for the reset piece. And there has been you know, a lot of individuals at senior have moved and changed. There's been you know, where the traction has been, it's been really hard if you're constantly moving within that to set that tone. We want this to be a supportive intervention for the Trust, and in the performance accountability frameworks we reviewed before this one, this is a mature relationship approach. This is about a system working together. Still have to be able to call out when we don't think things are as they need to be, but it is about saying, we believe these are the supports. What other supports do you need? But here are our very clear expectations of improvement. And that's why we've gone with this as a framework. We've seen it work already. Lisa can talk to it, but your time might be tight. But we have seen significant improvement. So it was implemented formally really end of November of last year. We have seen significant improvement that I don't think we would have seen before in the speed and how our trusts have responded. So I think it is helpful, but it doesn't mean it's easy.
Will there be, and lastly, just maybe even an examination of messaging? Because you know, whenever I think back to many workplaces and I think to many public spheres, things like racism, there is a zero tolerance taken towards things like racism, and racism is mentioned in the report, and it just it feels that out of this whole issue, it's but patient safety is okay, and we have to be careful for this, and we have to go. You know, it's about building into a culture that there are things that are acceptable and things that are not acceptable. No matter what role you're at, no matter how much you're paid, no matter what your seniority is, there is a line, and if somebody crosses it, then you're going to be moved out. And that is a message that needs to be instilled, because I think there still are some blurred lines around that messaging, typified by the fact that we're in year 10 has been suggested of this, year 9 of this going on. It's obvious that there's a message that's not getting through. So can we make sure that that message gets through to where it needs to get through to?
It's very much in line with what we want to do with the actions moving forward, and what we would like to see for the Trust. And I think changing a culture, if indeed it's wider spread, and I can't speak to that at this point because we haven't done the assessment, but if it was, that's not something that happens easily, you know, and it takes a lot of effort, and it will not be something that'll change overnight. And that anyone trying to change a culture, it's a long, hard slog to actually do it. But certainly from our perspective, we will be sticking with this. This isn't something we can tick boxes on recommendations and move away. This is something we have to support the Trust and hold to account at the same time. We will bring the right people to assist, and we do expect, and Minister's expectations is that he needs to see improvement, and he needs to see it fast. Where possible. Okay.
Thank you very much. Thank you, Chair.
Diane?
Yes, thank you, Chair, and thank you for coming. As Colin has just said, this has been going on for a long time. And given the number of people that have contacted me, it's not just within the cardiac unit. And it is about management and leadership in the Trust to actually deal with issues as they arise. We've had a Royal College of Surgery report, RQIA reports, GMC having certain folk in enhanced monitoring. We've had the PHA and SPPG yourselves conducting reports, and the Peter McBride report. Why are we only taking action now? Or was it just the fact that it was made public that shamed people into taking action? Tracey, I find that really, really difficult to act. I've looked at this, I don't know, many ways, and I find it difficult to comprehend how this was allowed to slide along for such a long time. And it has caused turmoil to people. And it has caused other people who work, good people who work, who turn up every day and work, to almost be undermined in the good work that they do. So why have we not taken action before now? I welcome that we are taking action, but why have we not done that up to now? Given the long history of this, the numerous reports, etc., etc.
So I think going back over the Royal College of Surgeons and General Medical Council intervention, both of those had actions, and both of those bodies settled that the actions were appropriate at that point in time. The difficulty is do we now understand why it either slid backwards into something that we weren't happy with, or whether this is a situation at this point in time? That's difficult to answer at this point. But I think that the report that the purpose of the report that was commissioned by myself and by Chief Executive and Public Health Agency at that time was as a result of knowing that other things had happened. And they've been closed down, and we all go, great, that's it, sorted, and something else has happened. This has to be a line from which we move forward, and we don't ever go back. So it's really hard to go back over at different points in time, recommendations, action, everyone's content, and then we come back to this. That's not acceptable, and it's not fair on the staff. And I wouldn't be defending that in any shape or form, but the purpose of the report and this time, and actually it was quite challenging to find a group of individuals with the experience and expertise. They have reviewed similar services, and it was important that we found a group who this time was very independent, very experienced, have been through this before. But for me, this was about the line in the sand. It was one of the first things on my desk as I took up the role at the end of last September. I know the energy that has been put in behind the scenes. Multiple. We have had daily situation reps. We have weekly escalations that I'm involved in. It has been significant. So I share concerns as to why we continue to go back. I'm not entirely clear at this point. We have absolute clarity as to why the interventions at that time that were accepted by those bodies seem to still not be holding.
Before you come in, Dan, Troy, I should say broadcasting are looking all members to turn the volume of our laptops down. There's some interference. So go ahead, Dan.
Oh, sorry. I suppose then the other thing is that the recommendations of this report give us recommendations around the governance of the trust. Recommendations which I think are massively important. And, the very first recommendation, the board should consider whether its current governance arrangements provide for a clear enough picture to be dealt of clinical risk and patient safety. And in the conclusions, it actually goes. It tells us that there is no effective reporting mechanism around this at board trust level. Is that acceptable? No. Will that be? But you're bound to have known about this. Why did nobody know about this? If the trust are not monitoring these kind of things, what are they doing?
The reason why we have the second expert in is to actually review the clinical oversight of those safety pieces. Now, it's not to say that the team are not looking at anything, but are they being most effective in the areas that they are looking at? We do not want to rely, and while I've said at the beginning, the data does indicate that relative to others, this unit has good patient outcomes compared to others. We don't want to rely on that, and you have to be curious in these things, and you have to make sure that you have the right expertise that understand the data that's coming. I haven't looked at the data. I wouldn't be an expert in looking at the clinical data. I wouldn't, if it comes into me, I'd be asking my experts. I'd be looking for the medics to translate for me, because I wouldn't want to presume and get it wrong. So it's just stepping back and looking at that. And again, the second expert, that's why we've really searched for the right person to come who has significant experience in clinical governance to make sure that that's one of the areas we look at. And support the trust. If it's not right now, does it need a small adjustment? Does it need a more major adjustment? That's what we need to get into in the details.
The report is quite clear that it doesn't have processes that actually look at this. So it's not that it needs an adjustment. It is quite clear that there isn't a process. I think that is a huge failure, and I'm not sure. I mean, I think that does need a huge amount of intervention to actually do that. The other thing that I wanted to raise, because it is actually really, really important that we understand this. The recommendations in this report conclude that we should be analysing the mortality data on these very extended waiting lists, because we have the longest waiting lists in the whole of the United Kingdom. Will there be a process to do that? because the report also talks about the number of people who are admitted as an emergency patient, because they've waited so long on the list that their situation has become unstable and they're now being admitted as an emergency patient. I think these kind of things are really massively important. I am quite gobsmacked, to be honest, that this hasn't been done. This wouldn't be a normal process. And I mean, it does actually say that the trust in the department should actually prioritise cardiac surgery. So there is actually, in a strange way, a positive for patients in that it's actually telling them to prioritise cardiac surgery. I just think these are very fundamental issues that this report addresses. Apart from all the headlines of bad behaviour, these are the fundamentals that the report addresses that are major importance and significance.
And I agree. I think it might be helpful if Lisa gives a little bit of an update to committee on the very point around the waiting list, because we have been working on the waiting list space and about building capacity within this service. It's a service that's quite small within Northern Ireland. There are, it's a specialist unit. So Lisa maybe can give just a bit of an update as to what we're doing at the minute, and then I'll come back to the governance piece, if that.
And I think, colleagues, I've given a couple of briefings in the past on the approach to waiting list, and up until this year we had been focusing on the red flag and time critical. One of the component parts of the time critical were those cardiac surgical cases. So we have an arrangement with a provider south of the border to actually provide additional capacity. But we are now working through, now that we have our recurrent funding through the Executive's commitment through the Programme for Government, we are looking to enhance that to actually look at other providers, because we have a backlog. It's not as long with the time critical as with some of our other routine patients, but we want to enhance that. But we also want to look at how we actually shore up our own and make our own team resilient. So we are working through a process of what does that look like for Belfast in the context of all of this being worked through. So will we be securing additional training posts? Will we be putting in additional consultants at a point in time? That's all currently being worked through, because cardiac surgery is one of our time critical, and this is our only provider trust doing it. So that's why this focuses on it. And just a couple of other points. The emergency presentations and mortalities, because of the long wait, our mortality work, it is at a point in time after treatment. But actually what we really need to try and do with our targeted actions to address our long waits is actually try and remove that all, so that we're waiting much shorter time and making sure that we direct resource in the most appropriate place. So we will always have clinical priorities, and cardiac surgery will always be a very high clinical priority, and it is for the trust. So we are looking to see what else do we need to do for additional lists. So it is an important. But you make an absolute critical point. When you've got the weights that we do have, there are emergency presentations, repeated emergency presentations, and there is an impact on not only patient experience, quality of life, ability to work, and it may actually impact on mortality.
And an efficiency of service, and how the staff have to respond to that imbalance between the planned care element and the emergencies coming in with the capacity. So we're very mindful of that, and actually with the focus this year and the Executive's commitment for the funding space and that commitment for us to move forward, we're able to do other things, and we're working in a different way to build that capacity in-house. We need to be mindful because we have a report here. So we're managing the oversight and the accountability of an issue, but at the same time we're trying to build the capacity and the resilience of a service to ensure that it is here for those who need it when they need it. So two sides of that, and it is difficult, and we don't want the waiting list the way they are. We want people to be able to access the planned care at the time they need. And there's quite a significant drive at the moment, not least with the new permanent secretary in place, to try and do that.
So I just 2 more points very, very quickly. I mean, the report also makes a recommendation about the high number of litigation cases within the Belfast Trust and about an independent review of those litigation cases. And obviously that's linked to the amount of money that's then paid out in relation to that. So I think that's important, but it's also important that we're looking at the governance issues within the Belfast Trust in relation to the capital build projects. And I hate to harp on about this, but the reason we're not doing other capital build projects is that we are soaking money into the Belfast Trust on capital build projects that have gone wrong. And so I think that we would not have a complete picture if we are not looking at the governance around the capital build projects. We have a maternity hospital 15 months after it has been handed over is still not safe for use and may now will require very significant work. So unless we're going to look at all aspects of governance, we will miss the trick on this, and we'll be back doing this over and over again.
So just on the capital bit, it's not an area, it's not that I don't have commentary on it at all, but it's not an area for myself. It would be another colleague who would come here. This is of such significance from a patient safety perspective that I think we need to focus in to get this moving. That doesn't mean there aren't other things that will be running in twin track alongside that, and my colleague Chris Matthews, who will have been here with you from policy side before, something we'll take back to him, your commentary on the other.
Danny?
Thank you, Chair. And thank you, like the rest of the committee, I'm very concerned about this. Those patients are critically ill patients and they're at risk of very, very serious incidents that may happen to them while they're waiting for their surgery. It's a very frightening time to be a cardiac patient awaiting surgery, and even more frightening now because of this. So there's a significant stress that has been added on to that. It's good to hear that we appear to be moving forward. I did want to ask just about the action plan. Co-design wise, how much input have you had from trade unions, from staff and organisations?
And I can't answer you that because I have literally opened it in a hotel room last night to have a very quick flick at it. But that's one of the questions we want, and that's why we've PCC are working, our Patient Client Council are working with the Trust as well, because this has to be something, there needs to be strands within this, trade union, the PCC and others. This has to be, as I said, a broad church of individuals who are coming to now make this, to make that.
Our input has been sought in designing this.
Do you remember their action plan is the trust-derived action plan? So that is one of the questions that we will come back. How have you designed it and co-designed? But that will be what will happen over the next number of days. My expectation is that it should be a broad spectrum of individuals, because if not, we'll start off on the wrong foot. Exactly. And we need to make sure. So that's really important. And I know the Trust have been receptive to those conversations. So I would imagine that it will be broad. And I think the updates and their oversight group, that will allow opportunities for other voices to be heard within that.
We are at an early stage, so I assume we'll hear more about that as it rolls.
Absolutely. Mm-hmm.
Thank you very much, and we'll look forward to seeing and hearing regular updates. Thank you. Members, we're going to go back now to item number 7, which is the oral briefing from the Department on the LCM for the rare cancers bill. So can I refer members to the notice of laying of the LCM, page 37. Bill was introduced, page 45, and also a range of cancer charities statements regarding the bill at page 52. So can I welcome Karen Simpson, Head of Medicine's Legislation Unit, Department of Health, Sean Curley, Principal Pharmaceutical Officer, Department of Health, and Rhonda Campbell, Assistant Director, HSC Research and Development within the PHA. So you're all very welcome. If you want to make brief opening remarks, that would be great.
Yep. Okay. Thank you for the opportunity to brief the Health Committee here today in relation to the Rare Cancers Bill and the Department's plans to progress with the legislative consent motion insofar as provisions contained in Clause 1 of that bill, as introduced, deals with the transferred matter of the regulation of medicines. As you and members will be aware, the Rare Cancers Bill was introduced in the House of Commons in Westminster on the 16th of October 2024 by Dr Scott Arthur of the Labour Party. The aim of this bill is to make provision to incentivise research and investment into the treatment of rare types of cancer and for connected purposes. If passed, the bill will introduce 3 measures intended to encourage more research, those being firstly the placing of a duty on the Secretary of State for Health and Social Care in England to promote and facilitate research into rare cancers, which will include the appointment of a national specialty lead for rare cancers. Secondly, the improving of patient recruitment into clinical trials for rare cancers through greater data sharing. And thirdly, the requiring of the government to review UK-wide law on marketing authorisations, product licence for orphan medicinal purposes, like diagnose, prevent or treat cancer. Rare cancers themselves are types of cancer that affect a relatively small numbers of people. The definition of a rare cancer can vary. The Rare Cancers Bill defines a rare cancer as a type of cancer that affects not more than 1 in 2,000 people in the UK. There are many different types of rare cancer. They include blood cancers, cancers affecting the female reproductive organs or digestive system, head and neck cancers, and cancers that affect soft tissues known as sarcoma. Orphan drugs are medicines that are used to treat rare conditions. They are known as orphan because pharmaceutical companies may be unwilling to invest in research and development for new treatments for diseases that only affect very small numbers of people. To help encourage more research and development, government offer incentives for the development of orphan medicines. As introduced, Clause 1 of the Rare Cancers Bill places a duty on the Secretary of State for Health and Social Care to carry out a review of the law related to marketing authorisations as set out in the Human Medicines Regulations 2012 in respect of orphan medicinal products for the diagnosis, prevention or treatment of cancer. Such a review must also consider regulatory approaches in other countries compared to the UK's approach by assessing international regulatory approaches for orphan medicinal purposes with a view to assessing whether the regulations in the UK are considered effective at encouraging research and development for treatments of rare cancers. It also requires that the conclusions of such a review must then be prepared and published in a report, and this report has to be published before the end of the period of 3 years, beginning with the day on which the Act is passed, should the bill become law. In addition, it is important to emphasise at this point that any proposed amendments to Human Medicines Regulations 2012, as a consequence of a review that may be conducted by the Secretary of State for Health, will remain as provided under the powers of the Medicines and Medical Devices Act 2021, to be consulted upon and made jointly on a UK-wide basis and subject to the draft affirmative procedure in both Houses of Parliament and in the Northern Ireland Assembly. With regard to stakeholder views, cancer charities that focus on rare cancers have expressed support for the bill and encouraged people to write to their MP to express their support for it in Parliament. Those include Brain Tumour Research and Pancreatic Cancer UK. Whilst we are primarily concerned about the progression of a legislative consent motion in respect of Clause 1 of the Rare Cancers Bill in relation to orphan medicines, the committee can be assured the Department, along with the Public Health Agency, have the necessary infrastructure in place to ensure there is equitable access to research in relation to rare cancer trials for patients living in Northern Ireland. This is achieved through the identification of studies through the Northern Ireland Cancer Trials Network's participation in UK and All Ireland Research Networks, which details then provided to relevant clinicians in Northern Ireland cancer centres. The Northern Ireland Cancer Trials Network provides support to any clinician wishing to open a trial site in Northern Ireland. Patients are also advised of the opportunity to sign up to be part of research which allow them to search for and be notified about relevant trials for their condition. I can advise that the Rare Cancers Bill passed its second reading in the House of Commons on the 14th of March 2025, with early July now likely for committee stage consideration of the bill in the House of Commons. At the executive meeting held on the 29th of May, the executive agreed to progress the legislative consent procedure in the Northern Ireland Assembly for Clause 1 of the Rare Cancers Bill in respect of orphan medicinal products for the diagnosis, prevention or treatment of cancer. and a legislative consent memorandum was then subsequently laid with the Assembly Business Office on the 3rd of June, and Assembly debate has now been provisionally scheduled for the 30th of June 2025. Thank you, and happy to take any questions.
Okay, thank you very much. So the Minister, in his correspondence to the committee, he highlights the lack of secondary use of data regulations present in the bill. So I mean, over a period of time I've been engaging with cancer charities. I met with the Cancer Registry. They and others have raised concerns in respect of the wider use of secondary data within cancer research. So can you maybe just provide the impacts of that within this bill, but also even specifically beyond that, you know, why these regulations are currently not in place, and if there's any intention or a timeline for progressing them?
Well, those regulations, well, they sit outside.
They do.
They sit outside this, but I am aware that there is to be an amending bill to be taken forward for the 2016 Act, which will then specify the regulation, the secondary care use regulations will then be developed after that. The timeline, I know Minister has prioritised for this Assembly mandate the amending Act, and it was hoped to be introduced before summer recess. I did check again today. I'm not sure if that's going to happen, depending on sort of timelines, but certainly early September, I would imagine that that amending bill will be introduced.
Okay,
to make amendments to the 2016
That would be very
Act.
good, because it's obviously an important issue.
And I think it is an issue for research. We recognise that about the data and the secondary use, so we want to prioritise that.
Okay, any other members? Danny?
Yep, thank you. Thanks for that. In terms of obligations that we placed on the Department of Health here, in terms of staffing, boarding, data infrastructure, will there be any additional funding from Westminster in related to this?
It'll be taken forward by DHSC. You know, so any of the review of the report will be taken forward by DHSC. Mm-hmm. So we will get the outworkings of it. But there'll be no cost to us because if there's any, it'll be a report. So if there's any amendments to be made to the human medicines regulations, obviously then my team will take those forward and come forward to yourselves. So I think the costing, looked at the assessment, was 140,000 for DHSC to look at this report, but there's no cost for us for the department.
Thank you. Thank you very much. Thank you.
Welcome.
Okay, members, can I just ask if members are content with the LCM as laid? Content? Okay, so the clerk will prepare a draft report outlining the committee's consideration of the LCM for next week's meeting. So moving on to draft SI on human medicines, item number 8. So can I refer members to tab 8, including clerk's memo, page 57, SL5, page 59, the draft SI at page 60, and an explanatory memorandum at page 68. Sorry, SL, I'm saying SI.
It's SI.
SI. Okay, well, I said SL first of all. So the committee was briefed on the draft SI on the 29th of May 2025 and agreed it was content with the merits of the proposed policy. There's been no change to the policy content since then. So can I ask if members are content of the draft SI? Okay, so members, we need to formally agree that the Committee for Health has considered draft SI, human medicines amendments relating to hub and spoke dispensing, etc. regulations 2025 and recommend that it be affirmed by the Assembly. Okay, so item number 9, written briefing from the Department on the General Dental Services Reform. Can I refer members to papers at tab 9? There's a written briefing there, and at page 8 of the table of papers, and I'll ask if members have any comments. None? Okay. Correspondence. Can I refer members to the correspondence at tab page 80, and can I ask if members are content with the suggested actions at the index, which are mostly noted down?
So could I ask, in relation to the letter from the parents for PEGs or whatever anyway, the issue around PEG surgery pathways, the letter is quite disturbing in that it indicates that some parents feel afraid to speak out to their consultant and so on. And I was just wondering, in Northern Ireland, we do not have a paediatric consultant looking at this particular issue that has tertiary or specific qualifications in this. And a couple of those parents have approached me asking around the idea of getting a second opinion from a consultant in, I'm going to say it's Sheffield, but I might not be right in that. I might have made that up, but it's certainly a consultant in England that they have the Belfast Trust has a relationship with, and their right to get a second opinion from a consultant that has a specific qualification in this. And I was wondering maybe if the committee would agree to write and ask about that position for those parents, because it is some of them are quite distressed by it.
Yep. I think that's eminently sensible. Everybody agreed? Mm-hmm. Okay, can I just point out or note the Department for the Economy's reply Caleb's cause?
Mm-hmm.
I think that's where they mentioned. I also note that the Minister has a statement in front of the Assembly, so we look forward to that. And also there's a Department of Health reply again in relation to Caleb's cause, and that's stating that there's going to be a regional protocol for transition has been agreed and is to be implemented by autumn. So I think that's positive work moving forward on that issue, and as we always do, pay tribute to Alma and her campaign. I think it's all worthy of support, and it's good to see that progress has been made across all of that. So is there anybody wanted to raise anything else? No?
Sorry, the ladies with the letters.
On the forward work programme. So, just even before we get to that, so then there's the Department of Health reply I should have raised in relation to the cervical screening programme. So, the department has confirmed that the data from the Southern Trust in the cervical screening programme was calculated using a different methodology than other standards. So, it might be worth asking why that was allowed to happen and what steps are being taken to ensure that all trusts align to the national screening performance measures going forward. If everybody's content. Okay. So, is everybody else content with the thing? So we're now moving on to the forward work programme. So we have the draft work programme. Dan, you wanted to come in?
Well, it's just that we keep the briefing on the 3rd of July and we keep the pressure on the department to actually furnish us with the reports. Yeah. That because if that's not going to happen, then it is September. Yeah. That's a long way away for those women who've waited a long time for that.
Sorry, members won't even know we had this conversation before. You jumped in before I even. So just to alert members to what Dan's talking about, the department had requested that the briefing that was supposed to take place on the cytology review be rescheduled until September. They had advised that a number of reports are due to be published in the coming weeks, but after the 3rd of July, but the 3rd of July briefing date, and therefore it might be more beneficial for members to be briefed after these reports have been published. But Diane's making the suggestion that we carry on with the
well, at least for now,
yep.
We do that.
Happy enough for that? We just go back to them and say we want to go ahead with it. Okay, thank you. Is everybody content then with the rest of the briefings that's set out in the forward work programme?
Maybe just on that, there's oral evidence on the draft human medicines on there. Is that something that can be optional if people see the papers, if they want an oral briefing on it? Because I'm conscious sometimes those guys come in and give a briefing and we all look at each other and nearly wink to say ask a question so that they don't. And those guys today spent probably an hour and a half or an hour 45 minutes out there, and 2 of them didn't speak because they're quite self-explanatory if you read them. But is there a way of something like that where we've already got 2 other oral briefings, if there's a third one, that if members specifically request the briefing, or does it have to happen?
Just to say, generally in relation to SL1s, which are proposals for statutory rules, we will take briefings on. They will generally just depend on the subject. Some of them are quite short, some of them longer. The only ones we tend not to take evidence on are some of the pension ones. If members wish to look at what's coming up and whether an oral briefing is needed, I'm happy to look at that, but generally our advice would be on SL1s when you get a chance to scrutinise it, even if it is a relatively short briefing.
Okay.
That we do that, but I'm happy to take members' guidance on
No, I
that.
was just wondering if there's an actual requirement or if there's something that we could opt into, but fair enough. If it's or maybe just to prepare them that it just needs to be a short briefing and that.
Yeah. And I mean, sometimes we get a briefing and then we hear the briefing orally, whereas we could just get the briefing, and if we want to ask questions based on that, I think that might be a better way. Even
I'm happy to go back to the department and saying someone will just go straight to questions.
If they provide the briefing, then we just go straight to questions.
Would it be something we could take earlier in the meeting as well, so that if we don't have questions, then they're sitting outside for 10 minutes and then go, rather than waiting the whole meeting if other items run over? But yeah, maybe.
Okay, so all right, we've already done that. We've already done that. Any other business? None. Okay. Date, time, place of next meeting, which is next Thursday, 19th of June, and room 29, 2 p.m. Thank you.